YouTube? Yes, ma'am. Yeah, we can see you.
Okay. Okay. Thank you.
So it's getting streamed live, sir.
Good morning, good afternoon, and good evening to all our esteemed delegates, those who connected with us across the globe. And it depends upon its morning, evening, or afternoon from where you are connected with us. I'm, in fact, delighted to welcome you to this comprehensive webinar on the foundations of echocardiography. With over 2,200 delegates from 82 countries registered, we are actually thrilled to see such a diverse and engaging audience. Your participation underscores the global commitment to advancing a field of echocardiography. Today, we've honored to host a galaxy of internationally acclaimed speakers who would share their expertise on various aspects of echocardiography and make your foundations of echocardiography more firm. So, from fundamental techniques to the latest advancements, our speakers would provide insights which would help you to deepen your understanding of echocardiography and sharpen your tools in this vital diagnostic method. This day event is streamed on YouTube, ensuring that our discussion reaches every nook and corner of the world. And we are committed to making this webinar as an interactive as possible. So we suggest that you please interact with the question answer session throughout the day of the webinar. I again thank you for being here and make best of this opportunity to hone your skills in echocardiography. Now I would introduce the chairperson, Dr. K Parashar, sir. Let me share my screen and then we would be good to go. Dr. K Parashar, sir, is the founder, of echocardiography in India, and he struggled so hard, and his seedling now has become such a good fruit-bearing tree. It's gone really big in a passage of time. He is currently consultant and director of non-invasive cardiovascular lab in New Delhi. He is MD, FACCC, FCSI, and FAE. He actually the founder of Indian Academy of Echocardiography, is the past president of Cardiology Society of India, past president of Indian Academy of Echocardiography, and he has multiple lifetime achievement awards from Ministry of Health and Family Welfare, Government of India, and from World Foundation Clinical and Preventive Cardiology, and also from the President, His Excellency. He is co-author of textbook of echocardiography. So I'll stop share here, and Dr. Parashar, sir, all over to you, sir. And I would share the slide again. So I would be the first speaker.
Thank you, Dr. Singh, UP Singh. I think this is a very great sort of a webinar like a foundations of echocardiography. Everybody does every view, but they don't know the intricacy and everything of the view, which is an ideal view, what you can see, what not you see or so. So this is a very apt webinar which you have kept for all persons, both from basics to advanced upwards. Because I have always these views, I have always followed 5 principles in echoing, in which I've always been successful in getting an imaging. Like you always look at the screen and not at the probe, especially those from the right side. See the respiration. They don't go on lifting the transducer, sliding, angulation. All this will help you. Now, the first talk of Dr. UP Singh, I don't know, he is such a great person, how to introduce him. He is a consultant cardiologist at the Prime Diagnostic Center, Chandigarh. In that region, or I would say in all over India, he is one of the largest experience in echo. And, and he was the first person to introduce 3D echo, fetal echo in this region of the world. And I would say that no conference in India is possible without his presentations. He's such an excellent person in this field. So please, Dr. UP Singh, you can continue with your talk. The most difficult talk in any echo meeting is the understanding of the physics of the ultrasound. So Dr. UP Singh, please.
Thank you, sir. It's very humbling to listen to such a nice words from a pioneer of echocardiography in India. Thank you very much for that, sir. I'm really honored to listen to what you said. Let me now share another screen. Okay. I would have to repeat. My first talk is on So I would have to open, just give me 1 minute and I would open that thing for. Is on image optimization. Yeah, you can see my last slide actually. So let me go to the first one. No, it's very important, once you are taking an image to have a very clean and good looking image, because the data, what you see and how you get the data is very, very important for the further interpretation of an echocardiography. So I'll take you through in a very interesting fashion. There was a TV serial which was breaking magician's code. The magician would actually show you what first would show the magic and then would tell you the secret, how he did it. Probably I would take you through an echocardiography in a similar fashion. So that's a young, beautiful lady who's been put in this box and they're going to rotate this box. And surprisingly, the lady's head is still up. Now, he tells you how he did all that. So there is a secret cabin inside, and you can watch it for yourself, how the things are done. And this is exactly what I would tell you. I'll show you a couple of images and then show you another image, and then I tell you the secret how I did it. Otherwise, teaching you physics or telling anybody physics of echocardiography is pretty boring. So that's how it's done. All right. So my first video clip shows LV, LA, and this is a 4-chamber view. And I think all of us would presume there is a, hypo or akinesia of an LV apex. And if you want to guess the ejection fraction, you would probably say it's about 30 to 35%. We did something, and now the image converts to hypertrophied cardiomyopathy with ejection fraction over 60%. The treatment, the management, everything goes for a toss. Now, how did I do it? It's simple. Now, there are three things. In this, I increase the power. Once you have an equipment, you have a TGC and you have a gain control, but these only change the brightness of the image on the screen only, not internally. If you want to increase the image power internally, you have to go to the power and then increase the amplitude of the ultrasound wave which you send. So that is possible by increasing the power. You would get a very good noise to tissue ratio. But the issue is that you have to keep looking at the MI and TI, thermal index and mechanical index. They should not exceed a particular limit. So in my machine, I could figure out the output power is here, it's in decibels. So if you increase it to 1, it actually is a multiple of rather than just doubled, right? So because it's an algorithmic format, so output power you should increase. Okay. Then whenever you're looking at the machine, look at the machine as if you are driving a car and that's the dashboard of the car. Okay. So where is the dashboard? Keep looking at the dashboard, and in case it's not on and you have an option of putting it off and on, keep it on, because you need to know what is happening. You have a frame rate here, you have a 2D parameter, what is the gain, what is the frequency you are using. Same is for the color Doppler, and what probe are you using, what is the TI and MI. These are the important things. Keep looking at this. But in case I have to look at only one thing, I think I would tell you I would look at the frame rate. Okay, another video clip. Yes, you suspect a similar kind of a case. There is an LA-LV, LA is enlarged in the 4-chamber view, but you suspect, yes, okay, it looks like hypertrophied cardiomyopathy and apical one. But when you do this, you can see it very nicely. Now, the image quality here and here are different, aren't they? Right? So I reduce just the depth to improve the frame rate. So frame rate here was lower, the frame rate here was higher because I just reduced the depth and I just focused on the area which I wanted to see. So just reducing the depth improved. So these are the ways of improving the frame rate, reduce the depth, reduce the width, and we use only a single focal zone. We hardly use multiple focal zones anyway. So in fetal echo, this becomes very, very important because you are looking at structures which are as small as the size of an almond. The heart size is the size of an almond in the fetal echo, around 20 weeks of gestation. So there, the frame rate is critically important. So if you improve your frame rate, the things are going to be better. Next video clip is a color Doppler of a patient with a 4-chamber view. You see the color Doppler right on the left frame, and then you see the color Doppler on the right clip. Is there a difference? Yes, the right one is looking better. Why? There is something called a color balance. Color balance, whenever you have an equipment, you can see a small bar around the color BART chart. Then this the bar is indicative of a color balance. What does it mean? That how much preference on the image you've given to the 2D versus the color Doppler. So once you're looking for a color Doppler information, you give more preference to the color Doppler rather than to 2D. By improving this balance between the two, and other equipment is called priority, you would be able to improve the things. So this is again, the balance was improved here. The balance and priority, just to example, if you give more priority or a balance to the 2D, the 2D information would be overwritten on the color Doppler information, and you would not get a very nice color fill. So this, I think, is simple. You don't see things too well, and because the reason was the Nyquist limit was very low here, and Nyquist limit is high. So you keep the Nyquist limit high when you are looking for. So it's the Nyquist limit issue in this. So in case ideal Nyquist limit in an adult echo is more than 50 centimeters per second, but there are areas of low flow where you have to keep it small. And I would show you an example there. So for example, this four chamber view, I've done almost everything to improve. We were not seeing the apex very well on a 2D, and there was a suspicion whether this was a thrombus or not. What we did was we reduced the size of the image, we reduced the depth, we have kept the Nyquist limit of around 19, low Nyquist limit, so that we know the velocities of blood as slow at the LV apex, and by keeping the Nyquist limit low, you would be able to see the color filling the apex. So you know that the color is going to the apex, and that's not the thrombus. This is just a accessory band. Second way you need to know is when you're looking for the coronary artery, you see the right coronary artery there, you keep the Nyquist limit low, and then when you scroll like this, and then you can see a color flow in the coronary artery. So once you've tried to visualize coronary arteries for reasons, then it's better. Now you see these two images, one on the left, on the right, and the right one, the color looks better, looks brighter. Very simple thing that you improve the smoothness of the color so that the gaps in between the pixels are filled by the computer, and it gives a little more smoother way of looking at the color Doppler. There are multiple ways to improve sensitivity and the color fill in your field of view. Then there's an increased ensemble, line density, packet size, persistence, and all these parameters are there in your equipment. Mind you, if you use all of them or either of them, they are going to reduce the frame rate. So remember, this is coming at the cost of reducing the color frame rate. To improve the frame rate, again, you can decrease the width of the color box to the minimum possible required. So these are the line density increase, size of the sample, ensemble. I think I would not discuss it in greater detail, but I would show you what it happens. Now that's the patient. This is an aorta cross section. That's the pulmonary artery. This is the pulmonary valve. You see a small jet of blood coming from the lateral aspect of the pulmonary artery. And we proved that this was a coronary to pulmonary AV fistula, which happens in about 2 or 3% of the coronary angiograms. That's what the data say. It's not very uncommon. So we see this jet, and then we reduced the velocity scale. You look at the velocity scale, we increase the priority here, given more priority to the color. Now you start seeing there is some vessel coming from here and then opening here. You think the things are getting better? Okay. So we then further improved, put everything into the system, increase smoothness, ensemble, and reduce the size, and look at the velocity. You can not only see that, you can also see the coronary vein associated with that coronary artery. That's a coronary artery and a coronary vein. This coronary artery actually joins the pulmonary artery, the small coronary to PA fistula. So if we had not done an improvement, we would have not got so far. So these are the summarizing the color Doppler controls, the balance, the color display and a 2D display, the Nyquist limit, the gain, the wall filters, the smoothness, and improving the sensitivity of color by line density, packet size, and ensemble. Please go back to your equipment and try to fiddle with each knob you have. You're not going to lose anything. You always can go to the default setting, but try each knob in your equipment and the primary the touchboard or the secondary screen. Just see whatever the knob is there, what it does to the image, so that once you need it, it's ready for your use. That's the patient where we used all our possible tools to improve. Look at the balance. We've kept it the maximum because we wanted to see the coronary artery, the color fill. And that was a patient which had a coronary to pulmonary vein fistula. Okay, so that coronary to pulmonary vein fistula is the left coronary artery. And then that's the fistula from the left coronary artery. And that fistula goes into the pulmonary vein and into the left atrium. I'm going to show you a few cases with a quick run because I have 5 minutes with me. It's 9:25. Now, this is color Doppler, and you can't make head and tail that there is an aortic regurgitation, stenosis, MR. I mean, it's very difficult. There is a lot of noise being produced on the color Doppler. And what we did was we did something and noise improved. So what did the magician do? This is actually what we call as wall filters. We have a high wall filters. Many times it gives a lot of reverberation from a calcified aortic valve, and that reverberation can be seen on an M mode, on a pulse Doppler. So every technique, the pulse Doppler sample is here. You can still see the aortic jet. The pulse Doppler is the back of the LA. You can still see it because the reverberation is going right till the end of the view field. And what we did was we increased the wall filter. That actually increased this reverberations. We reduce the wall filters, and so whenever you get this kind of thing from aortic valve vegetation, prosthetic valve, or any highly refractile tissue, you might get this what we call as a color Doppler thrill. Then what you do is that you lower the wall filters to improve, and you can see the aortic forward flow. Side lobe artifacts is very common. It's a common problem issue with our ultrasound beam, because we have one central ultrasound beam and then we have side lobes which become smaller and smaller. So you can have multiple side lobes, but usually the first side lobes around the side are important. Side lobe means that this is the pericardium and there is no pericardium here. The side lobe is produced and it looks like a membrane in the left atrium, but this actually is a side lobe of the pericardium. Then you see a side lobe of, again, a pericardium or some other structure, we don't know, but this is a side lobe. There was no dissection in this patient. This is a very common phenomena, what you see when you are doing a color Doppler of descending aorta. You see another descending aorta alongside. That is what is a side lobe. Do you think that this is a double orifice mitral valve with the mitral stenosis? But that's not true, because the second one is a reverberation which happens. The waves go and strike the transducer and come back and produce another shadow. It's like seeing somebody in the mirror. You can have multiple shadows. It's called reverberation image effects, and that you got to be aware. This reverberation can be present in M mode, 2D, everything. Electromagnetic interference, or EMI, that's what we call, is you can see usually in the middle of the field on the color Doppler. You see this noise here, with very irritating occasionally. Once you do a pulse Doppler here, you'll get a lot of noise, and you want to get rid of this. First, let us know what are the causes. It's actually caused by a magnetic field of the electrical instruments like a transformer, like an UPS. And here UPS stands for uninterrupted power supply and not Dr. UP Singh. All right. And inverters can do it. And LED light, we had to change the entire LED lights of our unit because they're drivers of LED light, which produce oscillations. They created electromagnetic interference, and it was very irritating. We had to spend money. We changed the entire lighting, LED lighting in our unit to buy lighting which was without EMI. That's a 4 years old child, which we did the cyanosis. This was a tetralogy of fellows. But more interesting than that, we saw some membrane here, and we was thought that this could be a dissection of the pulmonary artery, which is quite a rare complication of tetralogy of fellows. Surgeon said I didn't see any dissection whatsoever when he did the surgery. So now in retrospect, we presume that is an artifact coming from somewhere we don't know. But you got to be very sure what you're seeing and keep it in the back of the mind. It still could be an artifact, and you can't be dogmatic about anything. I'm going to share another 1 minute or 2 minutes for my slides. Now, what you see here is a small tricuspid valve jet. And what you see, the LA, RA, and RV are actually normal size. I mean, that's with a velocity of around 5 meters per second. Then you have a normal RA and RV. That is kind of unexpected thing. So why? No dyspnea, no symptoms, just 5 meters velocity. What is happening? And this is what is happening. Actually, it is not the TR, it is the Gerbaudet defects through the interventricular septum. Now you can see this PISA here, and PISA actually guides you where the opening is. The PISA is here in the interventricular septum, and then this goes through the tricuspid valve, and this is what we call as a Gerbaudet defect. That's the PISA, and through the VSD, you can have Gerbaudet defect, which could be acquired due to VSD, which is perimembranous VSD, and it's closed by tricuspid septal leaflet. And actually, it is now a gradient between the LV and RA, and it's not the gradient between RV and RA. So LV and RA gradient, 5 meter velocity, can be very easily expected. That's the patient. We were not sure. We saw some mass there. And that's what I tell you. You need to improve on your imaging. We optimize the image and look at the mass we saw. Not only that, we saw some satellite masses or some attachments on this mass. This patient had, and this was an RA thrombus, and basically this patient had polycythemia vera because of JAK2 gene abnormality, and the treatment was given. Now, this is the patient where you know that this is a myocardial infarction and there is a jet going this side. We can make a guess, yes, this is actually a ruptured interventricular septum, but you can make things more clear and better by improving your image on the right video clip. So reduce the depth to the desired. This is the patient with the TAPVC, and this we thought is the vertical vein, but we couldn't see the flow very well. And that's the pulmonary artery in aorta. And when you reduce the depth, you can see a flow in the vertical vein, which is going and opening into brachiocephalic vein. So if we want to see the coronary arteries, you reduce the depth to the desired level. Here we are. And not only that, you can see an artery and vein together if you reduce the depth. The near field clutter, you have some doubts here. And this near field clutter, the only way to do is to go through an orthogonal plane, and you can go from the subcostal view. I would share this in my subcostal view. You can go from subcostal view and look at the apex, There you won't get this near field clutter, and many a time you have LV thrombus. And how you want to see that LV thrombus, you just put the color Doppler, as I told you, with the reduced Nyquist limit, and you can see it's not filling there. But obviously the confirmation comes from a contrast echo, where you can see a nice this thing, hypertrophic cardiomyopathy. Even on a color Doppler, you're reducing the Nyquist limit, you can make out this is the jet of inflow and outflow. Rest is the thickening of the wall, and it's not the hypokinesia and the confirmation by our contrast imaging. So I think I would skip from here, and because I don't want to overshoot, but this is probably the last case I will show. This is a kind of a mass, what you see in the left atrial intraatrial septum, and we know that we have something called, this is not the same patient, we have the fatty infiltration into the intraatrial septum, which can look like this, but actually this was a tumor. So go for an unconventional views as well. Keep looking at the structure, and this structure was a mediastinal mass which was coming into the AV groove and entering. Thank you very much for your kind attention, and be a magician yourself today onwards. So I'll stop sharing here, and I'll share the PPT of all right. And
First of all, Dr. P Singh, you have made this talk so simple and educative. It was such a wonderful talk, and to see such nice cases. Possibly you should have a webinar only including you throughout the day, showing some nice cases.
Yeah.
Good job.
thank you, sir. Thank you, sir. I think I would request somebody to keep looking at the YouTube channel, and keep me posted in case there are any questions, and you can read out the questions. Rishi can do it, or Dr. Vijayalakshmi, let me share the screen first. Can you unshare your screen?
Yeah, sure.
Yeah. Because we don't want you to be present unless we formally introduce you. So here we are. Dr. Parashar, sir.
Yeah. So, as you know that Professor Vijayalakshmi is the most sought after pediatric cardiologist, both in India and abroad. Every time she shows photos with the legends of the pediatric cardiology in abroad or so. And if you see, she is a former professor and head of the Department of Pediatric Cardiology at Bangalore or so. And as she has written that she has got for the first lady cardiologist and first to start a pediatricology department in Karnataka. So what else do you want from a person of that stature? She has got multiple gold medals, right from 39 gold medals. I hope she has not sold them. And done pioneering work, acute rheumatic fever, which has been recognized all over the world and has been put into certain textbook or so. Other prestigious award, and besides that, she is the professor of the Indian Academy, president of the Indian Academy of Echocardiography. There are a lot of things to be said about her, but I think the time constraint is there. So let us see, give her a sort of very controversial talk on mode echo. Always Professor Feigenbaum says mode echo is not dead. So let us see what Professor Vijayalakshmi says. Please carry on.
Thank you, sir. So thank you very much for your kind words, sir. And as I'm sharing my screen, I would like to congratulate Dr. P Singh. And in fact, until I heard his lecture, I felt that I was like a person who learned cooking from my mother. I just picked it up. And today, after listening to you, like a master chef, you taught us how systematically, methodically, meticulously we can get a better image. So thank you very much for your presentation, as well as for arranging this wonderful global meet where all of us, we talk about 3D, 4D, but we have forgotten the basics. And today I'm going to talk about the applications of M-mode in our practice. And in fact, Dr. Parashar will remember that all the old timers, they started their career with the M-mode. Originally, it was described by Edler in 1961 when I was 11 years old. And in 1972, it was expanded, the utility was expanded when I just finished my medical school. So M-mode echocardiogram provides one-dimensional information regarding a particular cardiac structure as it relates to the time and the distance, with the time displayed on the horizontal axis and the depth or distance displayed on the vertical axis. M-mode depicts all motions down a line drawn through the tissues. It is a useful modality to measure the moving object, classically the cardiac walls, the interventricular septum, the valves, and the chambers. So a single recorded displayed graphically of which represent the acoustic impedance or density of the material encountered. These signals are subsequently displayed as dots and brightness of which is proportional to the amplitude and the reflected. Superior temporal resolution, ability to time events during the cardiac cycle, assess fast moving structures like valves and other things. So here, only the posterior leaflet moves posteriorly, remains open during the systole, visualizing the valve during the entire cardiac cycle, and that is difficult to get other than here. So the M-mode, we can measure the ventricles, all the dimensions that are given by the echocardiographer, the LVIDD, LVPD, the IVS, and all these dimensions are measured in the M-mode, and meticulously one has to know how to get a good M-mode picture so that the measurements are accurate. And then this is the M-mode in a dilated cardiomyopathy. Obviously, you can see that the LV is dilated and there is some amount of sec because of the slow movement, and also the systolic, the contractions are much less, and this is how the dilated cardiomyopathy looks like. And this is the M-mode which shows the dilated right ventricle with the paradoxical septal movement. And this is a classical picture or in case of atrial septal defect. Many times in the sinus venosus type of ASD, the IAS appears intact for the just on the visual appearance, but then when the M-mode gives you a clue that you're missing something. So if you have a dilated RV with a paradoxical septal, look for it. So many a times the coronary unroofed sinus and also the sinus venosus type, the IAS appears intact, but invariably there will be ASD. The M-mode in the hypertrophic obstructive cardiomyopathy is classic. And here you can see that the cavity of both the LV as well as the RV are reduced. And what you're seeing is the whole thing is the septum. The speckled appearance of the hypertrophic septum is here. And apart from that, the measurement of the posterior wall, the septum can be taken well to make the perfect diagnosis, because the septum has to be 1.5 times more than the posterior wall. So this is how it is very important. And apart from that, whether there is obstruction can be made out in this echo. And apart from that, the premature closure of the aortic valve can be made out. Here you can see that this is like a box-like appearance, and instead of box, you have got a premature closure. And this is how the premature closure and the flutter can be seen in the M-mode very well. So systolic anterior motion, or what is called as the SAM, is very important. SAM of the anteromitral leaflet in hypertrophic cardiomyopathy is considered to be anterior motion and the reopening of the mitral valve leaflets, causing the left ventricular outflow tract obstruction. However, SAM in patients without HCM is also seen, and this is because you can see that this is the SAM. You can So the SAM can occur in patients without hypertrophic cardiomyopathy, and it is well recognized causing the unexplained sudden hypertension in preoperative setting. Predisposing the factors that cause the SAM are excessive anteromitral leaflet, any anatomical or surgical transformation of the mitral valvotomy, and the supplementary clip. And these are very, very important because in the ICU, the SAM can occur in the post-operative patient, especially when they are in the hyperdynamic shock or when they have the LV contractility is increased because of the inotropic drugs. And the pericardial effusion is one thing which is very nicely, very accurately diagnosed by the MOD. And here you can see that surprisingly, we always talk about the RA collapse in the tamponade, and the RV collapse also can occur. And here you can see that there is a diastolic right ventricular collapse, and which is beautifully seen in the MOD. And this is how we know the pericardial effusion all round can be made out. So in the pericardial effusion, the effusion can be in the anterior or the posterior, and the collapse all can be made out. In a parasternal long axis view in a patient with the constrictive pericarditis, you can see that the pericardium is quite thickened, hyperechogenic, and apart from that, the MOD is showing the abnormal brisk oscillatory movement of the interventricular septum, and this is towards the ventricular during the expiration and towards the left during the inspiration. And this double-headed arrows are showing the double movement of the interventricular septum in the constrictive pericarditis. This is very pathognomonic. And the hyperechogenic thickened pericardium in constrictive pericarditis, here as Dr. Singh mentioned, you have to reduce the TGC so that all structures are reduced, and then in spite of that you have the hyperechogenic portion left, and that is the pericardium. And this is also very significant in diagnosing the constrictive pericarditis as well as the calcification of the pericardium. So this is the diagrammatic representation of the cardiac tamponade. As I told already, the RA collapse may be there, non-collapsing IVC will be there, RV collapse can be there, and apart from that, in the MOD, you can see the RV diastolic collapse, and this is how we know all the features can be made out in the MOD. The IVC non-collapsible can be measured, how much is the IVC dilated, and all that is possible. So intermittent RV diastolic collapse in cardiac tamponade is a classical pathognomonic picture, and that can be made out very well in the MOD. The diastolic collapse of the RV in the tamponade, apart from that, other features have to be made out, and even the any tumor or anything can be made out in that. So that if we see the tricuspid valve in the same frame as the mitral valve, think of the Epstein's anomaly. And that's how we know normally we don't see the mitral valve and tricuspid valve in the same person, but if you see them, think of the thing. The SAM due to the LVOT obstruction, Epstein's anomaly also can occur. So here you can see that there is a SAM, there is no hypertrophic cardiomyopathy, septum is not thickened. Well, this is because of the Epstein's anomaly. So here the Epstein's anomaly, the atrialized RV is dilated, and the tricuspid annular plane systolic excursion, what we call TAPSE, is traditionally measured by placing an MOD cursor at the lateral tricuspid annulus from the apical four-chamber view. And this TAPSE provides the rough estimate of the RV function by measuring the longitudinal shortening of the RV. However, it does not account for the radial shortening of the RV. The TAPSE score is an important parameter that determines the cardiac index and the cardiac ventricular function. The TAPSE measurement is common in adults, but reference in the children is not much, and it is very scarce. So TAPSE less than 17 millimeter indicates right ventricular systolic dysfunction. TAPSE less than 40 millimeter indicates the poor diagnostic in patients with the chronic heart failure. And that's how we know we have to measure the TAPSE to make out. Of course, now we have the 3D echo where a perfect LV RV function can be made out as in this 3D, but whatever we get in the MOD is an indicator to see that we have to measure the RV dysfunction. when we do the detailed study. Now, coming to the mode of the mitral valve in the diastole and in the systole, this is the diagrammatic representation. And here you can see that this is the E point, and this E point to the septum is also important. So the anteromitral leaflet looks like M and the posterior mitral leaflet looks like the W. And this is how the normal echo looks. But M mode can show the mitral stenosis very well. This is how the normal M mode is there. And in the mitral stenosis, the valve is thickened, both the posterior as well as the anteromitral leaflet are thickened, and the EF slope is reduced. And this is how it gives an indication that there is a mitral stenosis. And especially mitral stenosis with atrial fibrillation with the RR interval varying can be made out very well in the mode echo. And this is the one with the fast ventricular rate, atrial fibrillation with fast ventricular rate seen in the mitral stenosis. And here you can see that A waves, E point, F point, diastolic EF slope, and the B point CD segment all have to be measured so that our diagnosis is better. So this mode shows the E point, A point, and the D and the F and the C. And this is how EF slope has to be measured. And D is the end diastole, E stands for early opening, F stands for the mid diastolic closure, A stands for the atrial systole, and C stands for the closure of the mitral valve. Now coming to the EPSS, E point septal separation. This is the E, and from the E point to the septum we measure the separation. This is defined as the E point and or called as the EPSS. And in fact, this EPSS is so useful that even a person who is not trained to do the echocardiography, measure the LV function, can just measure this and tell that the person has got the LV failure. And that's how we know it can be used for the early detection of the LV failure. Normally, EPSS is no more than 6 millimeter. The distance gets bigger and bigger when the LV dysfunction worsens. So EPSS more than 7 millimeter is sensitive for the measurement of the systolic pressure, and that is equates to the or less than 30 ejection fraction. So we cannot measure the EPSS when there is a mitral stenosis or when there is an aortic regurgitation which is abutting on the anteromitral leaflet. So in both the condition, it will be erroneous. So in absence of mitral stenosis, atrial fibrillation, EPSS is a predictably a better indicator of the heart failure. So here in the M mode, we have to look at the mitral stenosis, AML flutter, aortic regurgitation, mitral valve prolapse, the flail mitral valve, vegetation on the mitral valve, LA thrombus, EPSS, all these parameters can be made out in the M mode. So M mode in the mitral valve prolapse, you get the hammock or you get the systolic bowing of the posterior mitral leaflet. And this is the bowing of the posterior mitral leaflet. And this is the classical picture. And this M mode is showing something, a mass in the LA. And this is the like ball wall thrombus, which the myxoma, which is coming like plopping into the mitral valve and going back. And so here you can see that in every systole, the myxoma is coming into the mitral valve. And this is the M mode where you can see that the LA thrombus is moving. And this is how the LA thrombus or myxoma, they can be made out in the M mode. The aortic valve, always it is like a rectangular box, and it has got an opening and then the closing. And this is very, very classical. And the size of the length, the height of it tells that the aortic valves are opening well. And when it becomes narrow, that shows that there is a aortic stenosis. And it can be thickened, calcified, dense, persistent. And here you can see that instead of box, it is the hyperechogenic one and it is narrowed. And if this valve separation is less than 4 millimeter, it is the severe or a critical aortic stenosis. Here you can see that there is an eccentric aortic valve opening and the it is less than 4 millimeter, and this is the critical stenosis. And there is the LV hypertrophy in the concentric hypertrophy in the M mode. And then this is the patient who had a 242 gradient across the aortic valve. So the M mode of the cusp separation correlates with the gradient also, and hence it is very important. So here you can see that in aortic stenosis, there is a narrowing, and the LV dimensions measurements are very important, especially in the LV, and that also helps us to make out the gradient, dimensions. And the diastolic flow reversal in the descending aorta is a very, very important point to be noted. And here, the holodiastolic flow reversal indicate that there is a severe aortic regurgitation. And this looks very, very funny. And anyone, looking at the dimension, the LA dilatation is gross. And apart from that, the LV also is dilated. And what is important is instead of a box, you are seeing something bellowing or ballooning out in the aorta. And this is the one which gives you a clue that something is wrong, and look carefully. And here you can see that this patient in fact had the aortic valve prolapse, and this is a redundant myxomatous aortic valve prolapsing, and that was seen in the M mode. And this is how we can, M mode gives us a clue not only for the AR and the cause of the AR and how the aortic valve is. And in the M mode, you can see the anteromitral lip flutter, and you can see that here the fluttering of the mitral valve AML is seen, and that is because the aortic jet hits on the AML and makes it like a flutter. And this is how the AR increased duration between E and A peaks, the flattening of the anteromitral leaflet, and that is seen very beautifully in the M mode, and that gives us a clue. And the B bump due to the elevated left ventricular diastolic pressure is also very important. Here you can see that there is a B bump, and that indicates that there is a LVDP is raised. In a parasternal long axis view, we measure, and that is the measurement is much better in the aortic valve. And here you can see that the early closure of the obstruction can be made out. And look at here, this MO tells that there is a AST. Fine. And then you can see that the pulmonary artery is dilated and pulmonary hypertension can be made out. So the M mode also helps in the tricuspid valve, and this tricuspid valve is very important. And before that, the pulmonary stenosis can be made out by the M mode, and the hypertrophied right ventricle can be made out, and the range of the gradient also can be made out. What is more important is Wolff's anomaly, which is one of the rarest of the rare one, and that also can be made out in case of in the M mode. And here you can see that the RV wall is seen, RV cavity, pericardial effusion, IVS, everything can be made out. And what is important is in the M mode, sorry. So here the ratio is very important. RVP to RVET ratio is very important. Normal is less than 0.3%, and to call it as pulmonary artery hypertension, it should be more than 0.35%. And this is how we know it is very important to measure all these things. And apart from that, whenever you have the B bump or the classical EF slope is reduced, or when the notch is mid-systolic notch is present, all these things are very important. This is the mid-systolic notch, and that occurs in the pulmonary hypertension. And this is how we know we can make out the pulmonary hypertension. And the TAPSE, I have already said that is important to make out the LV dysfunction and diastolic cardiomyopathy. And this is a very interesting case. Yesterday, while talking to Dr. Nitin Barclay, the past president, he showed me this case, and I felt it is fascinating and we should know about it. This is a 55 years old female with the exertional thing, and anyone doing the parasternal long axis or apical four chamber will say that there is a mild MR, nothing fascinating. But then wait, When you look at the ECG, there is a complete heart block. And what is important is when you put the M mode with the color Doppler, you can compare with the P wave, and the whole thing, the color Doppler shows there is the diastolic MR. This whole thing is the MR during the diastolic. So the diastolic MR is very, very rare, and this is in the apical port chamber. If you put the cursor on the MR jet, and you can see that this is the coinciding with the P wave, and that is the next QRS is not there, systole is not there. So what you are getting is the MR diastolic. So this diastolic MR is very, very significant, and that can be made out very well by the M mode echo. So why we have to do the M mode? There are many reasons, as I have told, and more important than that is M mode should not be forgotten. M mode is like a basic, which gives us a clue as to what all we have to look for. Like how the clinical examination is important, in the same way M mode is important for any echocardiography. So M mode echocardiography is commonly used for measurement of the myocardial wall thickness and the cavity dimensions, and is useful in estimating the ventricular cavity size for the calculation of the ventricular shortening fraction and estimate of the ventricular function. One obvious disadvantage of M mode is that it only displays a single ultrasound line. Moreover, the ultrasound line is fixed to the tip of the transducer, frequently making it difficult to obtain the representative section of the structural interest. And hence, this is the first echo machine called as the ultrasound, and that is in the 1953. And this is the M mode, black and white, and then precisely you can see where you're going. You see that the birds are diving, but where they're diving cannot be made out, but it makes you to think that there is something is happening. And this is the 2D echo. You can see that it is diving to catch the fish, and this is the 4D and the 3D, where clearly you can see how exactly it is catching the fish. And this is how we know the M mode is useful in making us to think what is important. So the pathologists make the perfect diagnosis, alas, a day too late, but the M mode can help us to make the diagnosis perfectly. Thank you very much for your kind and the patient hearing. And thank you, Dr. UP Singh. Thank you, Dr. Parashar ji. And thank all of you for your kind and the patient hearing. Thank you very much.
Thank you, Professor Vijayalakshmi. You have very well shown the significance of M mode, and we are of that age that we still believe in M mode as a good, but it should be well correlated with your 2D findings, but still it can give some useful information, except possibly we never say ejection fraction was M mode or so, but that is outdated or so. So I think you have stimulated the younger generation that not to forget about M mode. Yes. And thank you for showing some excellent imaging. Thank you. Well done.
Yes, sir.
Dr.
Your words
Vijay,
of wisdom are well taken, because most of the people think that M mode is useless, but not. In fact, it makes us look at what we have to look when we do the further echo. Thank you very much, sir. Thank you, Singh ji.
I think we have one question on the YouTube. This thing, Dr. Bimi Goyal thinks he's from Nagpur. She wanted to know what is your comment on ASC making guidelines that not to use an M mode for LV measurements.
I think when we have the other modalities like the 2D and the 4D echo, where perfectly measurements can be seen from the RA side and the LA side, I think depending on the M mode is not right, sir. M mode only gives you a clue that there is an ASD, look for it. Like as I said, sinus venosus can be missed, but then M mode tells us look carefully. And that's how it is. It is an indicator rather than a specific point to make the diagnosis.
Yeah, honestly speaking, I'll take Dr. Parashar's opinion also and Dr. Vinayak's opinion. See, I still use M mode for LV measurement. The reason being, why ASC said that it should not be used because of the angulation problem. And once you fix the angulation problem, and wherever you have an issue of angulation, then use 2D. You need to train your techs and your fellows accordingly. But if you use that way, M mode, you can't get a better resolution than M mode. You can't get better timing than M mode. What is your take, Vinayak, on this? What do you think? I still use M mode in about 40-50% of the patients for
No, I
for
completely
LV
agree.
calculation, for LV measurements. Yeah.
So I think what is clearly written is if you get a very good, say, horizontal, well-aligned parasternal long axis view, I don't think there is any problem in taking an M mode for the LV dimensions. And especially, so all that we recommend is to do 2D measurements is when you have an, say, angulated view, or if it is not a very well-aligned, M mode, which is cutting through a plane. So otherwise, I'm absolutely okay with that.
Thank you.
For
There was
EF
one.
calculation, I don't use. I don't use for T
Yeah,
codes.
well, that is a different thing. You should
That
not
is
So
use
UP
obsolete.
Singh,
either
in
2D
many
or M mode,
cases,
neither.
in
Neither.
many
Yeah.
cases, I have used both M mode and 2D, and I found a significant difference in the measurements. I agree with you. I still use M mode for these measurements or so, and sometimes, and now with the presence of an anatomical M mode, we can get slightly more horizontal images also. So I think many of us we still use these cases, but if suppose the M mode imaging is very bad, then of course we can use, but at least you say 44%. I see almost 60-70% that we use M mode for various, especially LV measurements and not other ones also.
There was one question asked for me. I would answer that on the YouTube, and that question was changing the Nyquist limit. I mean, changing the Nyquist limit on color Doppler has a different meaning, and we want to do it for something like when you do wanting to do a PISA method calculation of regurgitation volumes and extra. There you change the baseline. Otherwise, changing the baseline does not mean exactly the same thing as reducing the Nyquist limit. But I think in case you want to see the structures very with the low flow velocities, you reduce the Nyquist limit rather than changing the baseline shift of the color Doppler. Because then, if you change the color Doppler baseline, you won't know with the direction of flow because you change the baseline and you'll get the aliasing very quickly on the other side. So I think they are two different things to answer. I think before we go for the next speaker, I want to wish Dr. Parashar a happy Guru Purnima day today, sir. And you are our guru's
Thank you. Thank
guru,
you.
right? Yeah. So
Happy
Thank
Guru
you.
Purnima, sir. And to Dr. Vijayalakshmi ma'am also. Yeah.
yes, I think she's left and she's probably
Okay.
gone to attend. So yes, sir.
So now what to talk of Dr. Vinayak Agrawal? He is my right and left hand both in cases of echocardiography. Any conference, I never let him go because he can give him any topic anytime and he will talk on it. A very experienced one, and he is the senior director and head department of clinical cardiology and cardiac imaging as Fortis, and he has been shown that he's fellow of very prestigious societies also. He has he is part of our Indian Academy of Echo, and he is a course director for annual eco conferences also. And in many of our conferences, he is a regular sort of a presenter and especially excellent images on any topic. So Vinay, please go ahead.
Thank you, sir. I want to first of all thank Dr. UP Singh for actually coming up with this brilliant idea of reviving the concepts of fundamentals of echo. And I think he's somebody I've known now for a very long time who comes up with amazing ideas and concepts, somebody who's very passionate about cardiology and especially echo in particular. So thank you, Dr. UP Singh, for giving me this platform. And I'll share my slides. I've kept it. Okay, can you please deselect?
Okay.
Yeah.
1 minute.
Yeah.
Sorry.
So I've just got some very basic views, and I've also got one video which I'll share with you for the whole concept which I discussed with Dr. UP Singh initially was that we will start. This is a talk which is for the beginners, the basic fundamentals. How we make a 4-chamber, 2-chamber, 3-chamber views. So I have some initial video followed by some of the slides, and then some cases that we will discuss over this next few minutes. So I'm just going to start with my video first. So this is how we are putting the electrodes and the this I'm deliberately showing you because a lot of people do their echo studies without the ECG lead, and that is completely wrong. Without, yeah.
I think, Vinayak, there is issue of the audio from the system. I think you can speak again.
Let me see if this is working.
Yeah, I think you can speak yourself again.
Can you hear it?
Oh, no, we can't. We can't hear this because I think you selected the mic somewhere and the system mic doesn't work. I don't know. I
Okay.
really don't know.
Okay.
But I think what you do is that you can speak again.
I will. So what we are doing is I'm showing you the video of how the heart is placed in the cavity in the chest. So when we are making these views, we will show you so this is how the heart is placed in the chest, and you can see that it is more towards the center and only a part of it is projecting towards the left. If you look at the structures, so right from the top, this is the superior vena cava, aorta. This is the pulmonary artery, which is anterior to the aorta. This is the left atrial appendage, right atrial appendage, right ventricle, and left ventricle here. So this is how the heart is placed in the chest cavity. So when you open it up, you can see that these are the 4 chambers of the heart: left ventricle, mitral valve, interventricular septum. This is the right ventricle, left atrium, right atrium. The pulmonary artery is anterior to the aorta. This is the anterior mitral valve, and the posterior mitral valve is just behind it. So this is how the entire heart is oriented. And these are the pulmonary veins which are draining into the left atrium, and the superior vena cava, and inferior vena cava, both are entering into the right atrium. So, and this is the tricuspid valve. Now, if you look at this view, when we are putting the probe or transducer here at the apex of the heart, and if the marker is towards the right axilla, or towards the right side, to the left of the patient or right of you, and we'll show you. So this is the orientation of the heart, which will, when the probe is placed at the apex, that's how the scan planes will actually go and cut across the apex through the entire heart and give you this side sort of a 4-chamber. So this is a very basic orientation which you must understand. So, and now if you look at the transducer, we have got the index marker which is pointing towards the right axilla. So here the marker is facing outwards, and you can see that I'm placing the the probe in such a way that the scan lines, or the so-called fan, will cut across the heart near the apex and give you a slice of the heart. And now you can see that I'm making a 4-chamber view, and you can see the position of the transducer where the marker is facing outwards. And then just look at my hand movements. The hand movements are not fixed. They're moving a little bit. I'm maneuvering. These maneuvers are sliding, rotating, tilting. So all these maneuvers, sliding, etc., slicing, etc., are maneuvers which are recommended to make a good image. These are very, very important. So once you get an initial 4-chamber view, now you look at the screen. I've got a 4-chamber view. The 2 atria, the 2 ventricles, and these are inverted images because that's how the Fourier conversion is done, and the image is projected onto the screen. So left atrium, left ventricle, mitral valve, right atrium, right ventricle. This is the interventricular septum, and this is the interatrial septum. So this is, and you can adjust the view on the screen by very minimal movements of the hands once you've got a basic 4-chamber view. So it is very important to understand this concept. I'll show you again my hand movement. But before that, we'll identify the structure. So here in the left ventricle, you have a papillary muscle. You can zoom it. This is the anterolateral papillary muscle. You have the chordae, which are these thin threads which are coming from the papillary muscle attaching to the mitral valve. AML, A2 and P2 segments. So these thin structures which you're seeing here as we stop and show it to you. So these thin structures are the chordae. And you can have a false tendon here in the LV cavity. So you can see on the right ventricle also, I will show you the right ventricle. And you can also use the focus here to actually shift it towards the apex because the apex wasn't very clear. So you can get a more clear image of the apex. And it's very important to get a good tissue-blood interface. You have to see the endocardium very well, which you can see the endocardium so well. The papillary muscles, the chordae are very well seen. So you can see the AML and PML moving well. This is a normal heart. And if you put a color, you can see there is minimal physiological mitral regurgitation. You can see the inflow and outflow, the inflow of mitral valve. And this is the classical 4-chamber view. So you can also see the pulmonary veins, 1, 2, 3 pulmonary veins which are entering into the left atrium. And I'll just show you. So this is the right atrium, right ventricle. And if you tilt it a little bit, you can see the moderator band here. These are the papillary muscles of the tricuspid valve. And this is the septal tricuspid leaflet, which is attached to the annulus. And you can see the ATL on the lateral side. So you have a septal and ATL. And if you maneuver the ventricle, so we can talk about the leaflets later on when we're talking about the mitral and tricuspid valves. So this is a classical 4-chamber view. And you can see now here I'm showing you the 2-chamber view. And here you can see the anterior wall and the inferior wall. The mitral valve here. And if you go counterclockwise by another 60 degrees, you can see the aorta opens up, and that's the aortic valve, left atrium, the mitral valve, and left ventricle. And this is the anterior septum, and this is the posterior wall. So this is how we make 4-chamber, 2-chamber. And I'll show you now on the screen. So you have this view is for the 4-chamber. Right? Now this is the 4-chamber. And now again, I'll again show you the probe position. So I'm shifting and making some minor adjustments to get a nice 4-chamber. And from here, we rotate the probe counterclockwise by about 60 degrees. You will start getting the 2-chamber view. So this is a 2-chamber view here. Left atrium, left ventricle, anterior wall and inferior wall. If you rotate it further by 60 degrees, you will get a 3-chamber view. So you can see the 3-chamber view on your screens. So aorta, left atrium, left ventricle. Okay, now the suprasternal notch view. So this is the sternum, this is a suprasternal notch. And here, the aorta would be passing like this, giving rise to carotids on the left. And you have the arch, which is going down, giving rise to left subclavian, the left carotid, left subclavian. And here you have the brachiocephalic artery dividing into the right subclavian and right carotid. So here we're putting the transducer. The index marker is now facing towards the chin. So it's superiorly placed. So you place and then you tilt it about 1 o'clock towards the left shoulder of the patient. So now the cutting plane is between the, So the scan plane is actually from not this nipple, but the right nipple to the scapula, which is cutting from the right nipple to the scapula like this. And when you tilt it down, you will see the aortic arch. You can see the subclavian, the RP, right pulmonary artery, is that circle, and this is the descending thoracic aorta. So if you put color, you can see that there is a nice, the arch, and this is the descending thoracic aorta. This is the subclavian artery. You can see both the carotids here. So these are the, the subclavian and the carotids can be seen nicely. That's the right carotid. And you can see the ascending aorta here. That is the down here is the aortic valve. So you can see the entire arch now. Ascending aorta, the transverse arch, and the descending aorta. So this was the patient position. So I'm going to take some slides now from the 2019 ASC guidelines. And here we have already showed you the kind of different axes which we use to cut different planes and get different views. So for the apical plane, you have the ones which I showed you. This is the purple is the apical plane, and we rotate it by 60 degrees counterclockwise to obtain the 2C, and then another 60 degrees to obtain the 3C. So these are the various approaches you have the apical views, you have the parasternal views, right parasternal, apical, right apical, subcostal, and suprasternal notch. And these are some of the maneuvers like tilting, sweeping, rotating, sliding. Rocking is basically when you move the probe forward or backwards. The index marker goes forward or backwards, so you rock it. So these are some of the maneuvers which, as you start doing the echo yourself, you will realize these simple maneuvers which you can do while making good imaging planes. And these are some of the examples. So rotating the probe the way I showed you, so you can get a 4-chamber, 2-chamber, 3-chamber views. Rocking is moving the probe forward or backwards like this, that is rotating. Angling, you can angle the orientation marker away or angling towards the orientation marker. So this is also something which we do quite often. So this is how you do these maneuvers to obtain different images. Now, when we talk about 4-chamber view, these are the structures that you should be aware of, and it's important to look at these. So when you're cutting the plane, this is the view which you will get. So you have LA, RA, RV, LV, and I've already shown you on the live video. So I think we can skip this slide. And these are the other structures that I talked about, which is LA, mitral valve, LV. This is the moderator band here. You have the right ventricle, right atrium, and a tricuspid valve. And of course, this is how a 4-chamber looks like. This is a normal 4-chamber view. You can see both the atria and ventricles. And this is a color flow across the mitral valve. These are the normal views. And you can also identify the pulmonary veins. For example, in this view, you can see the pulmonary veins which are entering into the LA very clearly seen. And this is the apical 2-chamber view where you have LALV, and this is the mitral valve. You have the anterior wall here, and this is the inferior wall. And this is a zoomed up view of the left ventricle. So this is a typical normal 2-chamber view. You can see and the structures have been labeled. And the apical 3-chamber is, as I've shown you, where the aorta opens up. So you have the aorta, LA, LV, and mitral valve. So you have this classical 3-chamber view, which is also known as apical long axis view. And these are the structures. So aorta, aortic valve, LVOT is here, left atrium, left ventricle, and the mitral valve. So these are, how we take various views. So this is the parasternal long axis view, short axis view at the level of the apex, papillary muscle, and mitral valve. And these are the 4-chamber view with color, 2-chamber, and 3-chamber view. Just to give you a contrasting idea about the same, here I've got another patient who had an anterior wall MI, and here you can see plaques view, the term is akinetic. Short axis, you can see the entire LED territory is akinetic. And in 4-chamber view, you can see that this entire apex and the mid-basal septum, and of course the apex is completely akinetic and almost aneurysmal in looking aneurysmal in this patient. So this is an example of a patient who had an anterior wall MI and the LED territory is completely akinetic. Machines which can give you all the 3 views together. You also have the RV. Hello. So you also have the RV focused view, which is when you tilt the probe a little bit, so the entire image is tilted a little to the left, and you bring the right ventricle into the focus. So you have an RA, an RV, and this is the tricuspid valve. So this is called the RV focused view, where the RV is brought into the center. And you have the 5-chamber view where you anteriorly tilt the probe, so you open up the aorta, and you see the aortic valve, aorta, and the ALVOT. This becomes the 5-chamber view. And you also, if you push the probe back, tilt the probe backwards, Then you actually look at the coronary sinus, which is the most posterior structure just behind the LA in the AV groove. So you have the LV, RV, right atrium, coronary sinus, and this is the left atrium. And when you trace for LV cavity, say, for example, in a dilated cardiomyopathy, if you want to look at the volumes, please remember that the prominent trabeculae like these ones, or the papillary muscle like this one, have to be excluded. So they're included into the, you don't trace them. You have to include them actually into the measurement plane that you have, and they're considered part of the LV cavity. So you do not exclude them. You actually include them into the measurement area. These are the 17 segment models. So we can use, so what the American ASC recommends is that we start using the terms basal enteroseptum. So this is the enteroseptum, basal, mid, and apical. So mid and basal enteroseptum, and infralateral is, so this is, let's start with the 4-chamber view. Within the 4-chamber view, you have the infroseptum, because this is the septum where the aorta is not seen, so it is infroseptum. If you tilt open the aorta, then it becomes enteroseptum. So the 3-chamber view will have enteroseptum, while the 4-chamber view where the aorta is not seen is considered the infroseptum. And then you have the apical septum, apical lateral, and the lateral wall is no longer called lateral, it is called enterolateral, so basal and mid enterolateral wall. In the 2-chamber view, you have the anterior wall, which is basal, mid, and apical anterior wall, which remains the same. The inferior also remains the same, inferior, basal, mid, and inferior. So basically the difference is in the septum, how it is pronounced. So instead of anterior septum, we call it enteroseptum, which is the same. And the lateral wall and the posterior wall. So now the lateral wall is called anterolateral wall, while the posterior wall is called the infralateral wall. So this is the infralateral wall. And this is how the nomenclature now is recommended. And the 17th segment is the apical cap here, which remains the same in nomenclature. This is also very important here to look at the segmental coronary supply. So if you look at let's start with the LED, which is this green. So you can see the LED is something which is starting from the apical apex, apical septum, goes down all the way, can actually be involving the lateral wall. So if you see the shaded area, so green and these pink lines are where there is an overlap between the LAD and the circumflex artery. So you can see that this area can be supplied by the LAD or circumflex, but classically the lateral wall is supplied by the circumflex territory. LAD territory is the anterior wall and the apex classically. So the entire enteroseptum, apex, anterior wall will be supplied by the LAD. Coming to the circumflex territory, we have already shown you that this is the circumflex territory. The posterior wall and the lateral wall, posterolateral walls are usually supplied by the circumflex artery. There can be overlaps, but classically RCA will supply the mid-basal septum, which is the PDA territory here, and the inferior wall. Also, the RV is supplied by the RV branch coming from the right coronary artery. So this is how the segmental coronary supply is in usual cases. Then of course, there can be overlaps, and depending on the dominant circumflex or RCA, you can have a variability in how the blood supply occurs. Information ascending aorta, and I have already shown you how to do the imaging. But what you see is the ascending aorta. This is the right pulmonary artery. You have the transverse arch. you have the innominate, left carotid, and the left subclavian arteries, which are seen in this arch. And then you have the descending thoracic aorta. So this is a classical suprasternal notch view. I can show you some examples where you can see the suprasternal notch view. So this is the aorta, the ascending aorta, transverse arch, and then the descending thoracic aorta. And here you can see the ascending aorta, the descending aorta, and the transverse arch. So this is how the schematic is shown to you. And this is the right parasternal view. I did not show you on the live, say, demonstration, but here it is exactly the same as parasternal long axis view, but you tilt the patient to his right, and then you image at the right parasternal area where the probe is actually put, on the right side of the sternum. It has to be learned specifically. You have to adjust, and there is a learning curve attached to it. But for all practical purposes, this is the view that you will see. So you'll have an aortic root. LVOT is here. This is the aortic valve, and this is the ascending aorta. So this is how the blood can.
Dr. Vinayak, your signal is not coming. I think your Wi-Fi connection is quite
Abscess.
unstable. But then now it's getting better. Okay.
Okay. Can you hear me now?
Yeah.
Okay. So you can see that there is a infective endocarditis. This is the abscess cavity, and there is a leakage. There is a severe aortic regurgitation, which you can see, and of course there is aortic. All the chamber views. So this is a 4-chamber view, 2-chamber view, 3-chamber view. This is the 5-chamber view where the aorta is opened, and this is aortic regurgitation, which you can see here. And I have obtained a continuous wave Doppler across the aortic valve, and you get a gradient of about 44-45 millimeters of mercury. Now, if I do a right parasternal view, you can see this is the aortic valve, this is the root, the ascending aorta, and you can see the jet of severe aortic stenosis. You can see below is the arch, the suprasternal notch view. You can see there is the descending thoracic aorta shows flow reversal, and you can put the pulse wave Doppler, and you can see diastolic flow reversal in the descending thoracic aorta, which tells you that this aortic regurgitation is severe. But if you look at the gradients obtained through this because of the better alignment. Here the mean PG is 58, almost 10 to 12, almost 13 millimeter more than what you obtained in the 5-chamber view. So this is the good part about the right parasternal, and this.
Vinayak, you're only intermittently audible.
Vinayak, maybe you can complete the talk, once you get a good connection. And have you moved to a place better?
I can try and
I think it's looking okay now.
my
Just go ahead. Just go ahead. Yes.
Okay. So this is a patient who has large apical aneurysm. So this is a 4-chamber view. You can see a large apical aneurysm here, which is because of the late presentation of an interior wall MI. There is no mitral regurgitation. So this is a color flow Doppler across the mitral valve. And these are the two-chamber views. You can see a large apical aneurysm in 4 and 2-chamber views. This is the tricuspid valve. And you can use you can measure the volumes by tracing the endocardial border, and it tells you that the ejection fraction is only 16% in this case. The ejection fraction about 21 to 22% or so, with very large LV volume of nearly 378 ml. So this is another example where you can see this patient has large anterior wall MI, and the wall motion can be seen very easily. The entire LAD territory is akinetic, and so is the inferior wall. So you can see that the inferior wall, almost the entire heart is actually hypofunctioning. So there are some areas which are akinetic, like the LAD territory and the RCA territory, and the posterior and the lateral wall are showing they're showing hypokinesia. So this kind of a patient has again very low ejection fraction of nearly 17% or so. Another patient, diabetic, 45-year-old smoker. Now again you can see that there is significant LV dysfunction. This is a parasternal long axis view, short axis view, with moderate mitral regurgitation. And again, you can see the entire LAD territory and the inferior wall as the apex. You have all the 4 chambers dilated, mitral regurgitation of moderate severity. And you can see that the inferior wall is also akinetic here. Anterior wall is also akinetic. So this kind of a patient has an ejection fraction of hardly 15 to 20%, with TR showing around PA pressures around 32, and some significant pulmonary regurgitation also. Ejection fraction here was around 23% again. So you can see, how it is important to know these views very well and how to make them, consistently in the appropriate manner. This is another patient with hypertensive emergency with very high blood pressures when he came to the emergency. And you can see a plaque view with very thick ventricular walls with altered myocardial texture. And if you look at the ejection fraction, again, it is on the lower side. And here you can see a global hypokinesia, and significant thickening of the left ventricular hypertrophy is significant globally. And left atrium is enlarged. The left ventricle is hypertrophied and hypokinetic globally. So this patient had hypertensive heart disease, and a lot of times when you have controlled the blood pressure, etc. So here is more advanced echo, which we will discuss later on in other, lectures. But here the left atrial strain was markedly reduced at 12%, and the GLS, global longitudinal strain of the left ventricle, was also markedly reduced at -8%. So I can show you another. So this is a spot diagnosis for people who know. You can see that the posterior wall, the basal lateral wall, and inferior wall, there are aneurysm here in the inferior wall. So this is a hallmark of sarcoidosis. This kind of aneurysms are most commonly seen. And also you can see that the basal anterior septum is hypokinetic and little echogenic in this case. So these are spot diagnoses. This is another patient who had non-compaction of myocardium, which actually turned out to be sarcoidosis. And here again, you can see a lot of hypertrabeculations in the left ventricle here and here. So you can see the hypertrabeculations here. This patient was not left ventricular non-compaction, but actually turned out to be sarcoid. This is a patient, again, who presented with apical. So left ventricle, you can see the left atrium is large and the left ventricle looks small, but at the apex, you can see there is an obliteration of the apex here. So this was a case of EMF. This is another case of posterolateral MI, where you can see that the lateral wall has ruptured and there is a large pseudoaneurysm here. I'll show you another views to show it better. So you can see this is a modified view where the lateral wall is ruptured and you have a large aneurysm, which is seen in this patient. This is a case of right ventricular MI. So this right ventricle is hypokinetic and dilated. You have another patient who came with MI, anterior wall MI, but here the left ventricular apex is dissected. This is known as the intramyocardial hemorrhage or hematoma. This is the dissection flap. This is not a clot, which is most commonly mistaken. These are the patients where you have large pericardial effusion with medulla head-like appearance. Just wanted to show you that sometimes you will have distorted views where this is the left ventricle. This is actually a 4-chamber view, but then because of its large pericardial effusion, it is looking distorted. So this is a parasternal long axis view, short axis view, and this is the 4-chamber view. Another case of SLE with acute decompensated heart failure, you have a left atrial clot here. The left ventricle is hypokinetic, EF is about 25-30% hardly. And you can see a large LA clot and severely decreased LV function, systolic function. And this is another case of hypercoagulable state in APLA with SLE. You can see biventricular clots, severe hypokinesia of the left ventricle, and large clot here. And this is a contrast study of the same patient. You can see the right ventricular apical clot and the entire clot in the left ventricle, which is lining the anterolateral wall and apex. This is another case of EMF, biventricular EMF. You have the LV apical. This is a 4-chamber view, biatrial enlargement. And look at the RV apex and the LV apex, both are obliterated in biventricular EMF. So this is another patient who had peripheral gangrene, had turned out to be antiphospholipid antibody syndrome. So these are the right focused RV view where the RV is in the center. You can't see the left ventricle. So this is the RV, RA, and these are wide open tricuspid valve with severe tricuspid regurgitation. And this is the 3D view with open tricuspid valve. This was another interesting case patient, but this is a transesophageal echo, so we'll skip it. And this is a case which again is very interesting because patient was in sepsis with CKD, had a permacath. You can see there is a pericardial effusion. There are features of tamponade and 4-chamber view where the apex is akinetic. So this was actually an apical ballooning syndrome. Patient had normal coronaries later on. And again, this patient had pericardial effusion. There was also a clot attached to the permacath. So this is called the catheter-related RA thrombus of CRAT. Patient had tamponade features, pericardial effusion, and apical ballooning syndrome. So this is what the CRAT looks like. This is the thrombus and this is the permacath in the right atrium. So this is the last case I'll show just to show you the importance of 4-chamber. So this patient presented with a wide curious tachycardia VT with LVBB morphology. And this is the 4-chamber view. So here you can see that this is the left ventricle and this is huge is the right ventricle and right atrium here with non-coaptation of the tricuspid valve. And there is an aneurysm at the apex and it is a thinned out right ventricle. So this one was actually a case of arrhythmogenic right ventricular cardiomyopathy or ARVC with severe TR. This patient eventually had to be shifted for a cardiac transplant later on. And this is another case of pulmonary embolism where you can see this is the Black's view, the left ventricle. This is the right ventricle, which we'll show you in the 4-chamber view. So you can see this 4-chamber view is distorted. So left ventricle, left atrium, but look at the RV and RA, huge. And you can see clots in the RV with severe TR and severe pulmonary hypertension. And this is the parasternal short axis view where you're seeing the clot in the pulmonary artery at the bifurcation. So I think I will end with this last one where patient presented with raccoon eyes. And this is the 4-chamber view, which is a classical of amyloid. So Thank you so much. And
Thank you, Dr. Vinayak. Wonderful. I think there was a bit of an issue of, internet connectivity, your videos and your this thing. There was a lag because Zoom actually manages the audio. It compresses your audio and it makes you speak faster. But beside that, there were excellent cases, Dr. Vinayak. There is a question from Dr. Tarun Sharma. He wants to, learn how do you manage a patient with the dextrocardia? I presume that he's talking about a mirror image dextrocardia, okay, and or situs inversus totalis. So, how do you manage when you get this kind of patient?
so basically, in this, what we do is we change the position of the probe. The marker is now tilted to the other side. Exactly in the same way, uh, we the you'll make the plaques and other views exactly in the same way, but the marker, the index marker will be changed differently. I don't know if we can show him with some video later on where how to actually place the probe and scan it.
Yes, yes, yes. I think that's a very good suggestion. I think that's exactly what we all do, rather than making an assessment on an inverted kind of thing. We just invert our probe to the marker starts pointing on the right side, while on the screen it's showing on the right, it's showing on the left, and the you reverse the position with your probe, not going with the screen what the marker shows on the screen, actually on the other side. Correct. Anything, Dr. Satish, and both Dr. Satish, Dr. Parashar, and Dr. Govind can answer. So, what is your take on this dextrocardia?
Govind and
Dr. Satish, sorry. Oh, yeah.
you are not audible.
Yeah. I made it.
Dr. UP,
Yes,
you
sir.
will have to give me some 10 minutes. There's one unfortunately bad timing. There's a procession going on right now.
All right.
Noise here. So just give me about 10 minutes or so.
Sure. So, I think next is your talk only. Do you think I should take my talk of subcostal views then, in case you are stuck?
I would suggest that if you can take it, they're bang opposite my road. So it'll
All
take
right.
about 10 minutes or so.
Okay. So
Not a
I
long-
do that. I do that. And Dr. P Singh has, happy Guru Purnima, Dr. P Singh. He was also my mentor and teacher for both academic and non-academic, things. He knows it well. He says that we should begin echo with an M mode, as old timers. We all do it, and we learn, and otherwise we'll forget this technique of M mode, which is very, very useful to actually uh, time the events, because there's not can't be anything better for timing the events than an M mode. So in that scenario, Dr. Parashar, in the meantime, would you introduce Dr. Satish Govind, and maybe after that I might run some promotional video, and then by the time maybe the possession, whatever we have it there in Bangalore can go.
Dr. UP,
Sure.
I need about 10 minutes or so. So
All right. We just try to, let us introduce you in the meantime. Then maybe I can take the talk. Dr. Parashar, sir.
So I think Dr. Satish Govind again, my great friend, and I would say mentor. He's non-invasive cardiology at Narayana Institute of Cardiac Sciences, Bangalore, and he is an immediate past president of the Indian Academy of Echo and the past editor of the Our. Now he is extremely competent in various structural heart diseases including the various 3D aspects and their management also. And he has authored many chapters in cardiology books and journals also, and numerous eco conferences. And as I said, he's keenly interested in structural heart interventions, heart failure, pulmonary hypertension, and specialized eco procedures. And whenever we want any talk on a 3D echo or a structural intervention or any other aspect, then we always lean toward Satish Govind. So I think it is good to have him with us, and then he can share his experiences also. Thank you so much.
Thank you, sir.
So I think in the meantime, let me deliver my talk because all right. So let me check my systems. All okay? Yes. Okay. So let me begin my talk instead. Doctor. All right. Let me change the. Okay. Okay. I have to open my PowerPoint so that. So I'll discuss subcostal views, sir, in the meantime, when till the time when sir gets free from that issue. So, all right. So there we are. So subcostal views. Subcostal views are actually challenging and difficult, but most of the times that's the only view which is available to us. So when the apical window is inadequate in the form of, let's say, a person has an asthma or an emphysema, or whether it's a subcutaneous emphysema. Therefore, yesterday we had a patient with a subcutaneous emphysema because of the chest tube was put, and we couldn't see anything on the apical views whatsoever. We tried. We get some window from the parasternal long axis view, but we had to resort to subcostal views. So practice subcostal views now, because once you are stuck with a case, that's not the time when you start practicing subcostal view. So start practicing subcostal views right now. It's a good idea because for firefighting, you actually do a fire drills before and God forbid any event happens. So there's some structures which are seen very well on a subcostal view, even if you have a good adequate four-chamber windows or apical parasternal windows. Inferior vena cava, certain types of NASD, in particular the sinus venosus, both inferior and superior sinus venosus kind of ASDs are best seen with this. RV for wall thickness is recommended because then you are kind of perpendicular to the right ventricular wall, and that's where it is actually internationally recommended to take a measurement of RV wall thickness. Certain structures in the right atrium, including the normal ones like Eustachian valves or cherry malformation or some tumors, I'll show you plenty of cases, don't worry. So pericardium, again, subcostal view, because many a time in case you have to do a pericardiocentesis, you do from a subcostal window and you make an assessment of the depths and other things from a subcostal window. The RV mid cavity, and particularly the patients of double chamber right ventricle, you are actually perpendicular to the double chamber right ventricle obstruction when you are doing from a parasternal long axis or a short axis views. So then the Doppler things would not come nice. So for that, what we need to do is that you go to subcostal view where you get a very nice window of RVOT where you can actually put a CW Doppler to have a very nice parallel window to the beam. Many a time LV apex, as I told you in my previous talk, if you have proximal clutter, which cannot be avoided by in many patients with apical four-chamber view because of the clutter, because there's a lot of noise there. You can't see the LV apex even if you are very close to it. Then you have to move to an orthogonal view. The view would be from the subcostal, and then you look at the apex. I am going to spend little time here on how to do subcostal views. Probe position is the most important thing. And you notice here the probe position from the view from the top and view from the side. You notice the probe. This is the marker on the probe, which tells you the side. And then it has to be on the left side in long axis view. So these are the long axis views where which the probe has to be in this direction, but you make it actually 90-degree to make it a short axis views. And this is how now the angle is the probe, and that's the marker on the probe. I'm going to give you a demonstration which we recorded recently for the same. And that's the patient which the very first thing you need to do is bend the knees to relax the abdominal muscles so that you can move the probe posteriorly. And notice here, and I'm just showing you the marker. So the marker has to be on the left side, as the marker here on the screen is also left side. So first, the longitudinal views. In this views, you actually sweep the probe posterior to anterior and lateral. And then for short axis views, and you move the probe from right to left as a sweep to get these kind of various views. Not to worry, I'm going to repeat how to do subcostal views in multiple ways or repeatedly, so that you get very accustomed to all possible subcostal views. To summarize and begin, the patient has to be supine, and you put the probe in below the xiphisternum as high as possible in this xiphisternal angle. Because if you put it somewhere here, and in my experience, wider this angle, the better echo window you get. If this is narrow, this angle, subcostal angle is narrow, then you don't get good views in those patients. Okay, and then hold the probe with the palm, and you can actually have to put it with the pressure little deeper so that get a better window, and then the depth has to be adjusted accordingly. The very first thing, the long axis views, which I showed you the probe position. Now, in the long short views, the first view is the coronary sinus. The second view is a kind of an apical four-chamber view, and where the structure you must recognize. This is the right atrium, this is the right ventricle, and this is where the right ventricle wall is actually perpendicular to our beam, and that's the best place where you take right ventricular dimensions of the thickness, because this is where is the best place to do it. Then this is the tricuspid valve. The RV, what you see would be a very foreshortened RV, because you don't see an RV apex or an outflow. This is just a part of RV inflow. So RV looks quite small or foreshortened. Then you see the interventricular septum separating the RV and the left ventricle, and this left ventricle again is foreshortened because you don't see an apex of the ventricle here. Then that's the mitral valve. That's the posterior wall of the left or the lateral wall. This is the interventricular septum. That's the posterolateral wall of anterolateral wall of the left ventricle. Then you have a left atrium. You can see the pulmonary veins also here, and you can see the coronary sinus if you are angled little more posteriorly. And on the side, you can see the inferior vena cava entering. This is the best view again for two things. One is the RV is perpendicular. Secondly, the interatrial septum also is perpendicular to the beam. And in case you want to see the color Doppler, which is parallel to the beam. So color Doppler is the best when you are parallel to the beam, and 2D is better when you are perpendicular to the ultrasound beam. So here, if you are parallel to the beam, is there any ASD or a PFO, the flows are best seen on a subcostal view. Another thing, the tricuspid valve leaflet, the posterior leaflet is said to be the best seen on a subcostal view. I think I'll go a shade before that, because that's something which is very, very important. When you are doing a congenital heart disease study, you always have to start with this view. This is a cross-sectional view where your probe is absolutely perpendicular to the abdominal wall. You are actually doing a cross-sectional of abdomen, where abdominal aorta and inferior vena cava are seen in relation. That's very important to demonstrate here. That is the spine, and it's the shadow of the vertebra. And that is an aorta, and this is one vessel of aorta, more probably the celiac axis. Then this is the probably the renal vein, renal artery, the right one, and then IVC, which is collapsing. And remember, the aorta is to the left of the spine, and IVC is to the right of the spine, and the liver is on the right side. And if the liver is on the right side, this is what we call as a situs solitus position, and the things can change in congenital heart disease. The aorta can be on the right side, IVC can be on the left side, liver can be on the left side, or can be in the middle line in patients with situs inversus totalis, or in heterotaxis where you have left or right atrial isomerisms. Then, as I told you, the next view should be where you see the interatrial septum. You would have a thicker portion of interatrial septum on the sides. In the middle, you would see a thin fossa ovalis kind of structure, which is thinnest portion of interatrial septum, and that many a times appears as a dropout in a four-chamber view, and you see and think that it's an ASD. I would show you a case for that, and if you then move to the subcostal view, and you can actually demonstrate that if there is no flow, which you are in the absolute right direction parallel to the beam, and if the color flow is not seen across the ASD, then it was just a dropout. So again, recognizing structure, the liver is the most anterior thing after the abdominal wall, fat and muscles. Then you see the pericardium, the shining, glistening thing. Here, posteriorly also you see the pericardium. Then you see the right atrial wall, interatrial septum, the right ventricular wall. Right ventricle is foreshortened. That is one of the papillary muscles. This is the tricuspid valve and leaflets. The mitral leaflets here, the left ventricle lateral wall, the interventricular septum, and that is the left atrial posterior wall. And then you see that could be a pulmonary vein. On the live video, you can again see this is an LV. That is the tricuspid septal leaflet. That's the posterior leaflet of the tricuspid valve. This is the right atrium, interatrial septum, and interventricular septum. The right ventricle is shortened. You see the septal papillary muscle with the chordae and few chordae attaching directly to the interventricular septum. We move the probe little more anteriorly, And then by that angulation, you start seeing the aorta coming out of this, and that's an aortic valve. And many a time, if you don't get a good echo window, you can align the window here and take the gradients of the aortic valve from this place. And that's the video of the same. The left ventricle, the aorta, you can see the aortic valve, and you can see the blood flow if you put the color Doppler on. So this is slight angulation here when the aorta is seen. You move further, still more anteriorly. This is a difficult view to get because you are quite anterior, and many a time because of the lung position, you may not be able to get this view very nicely or very clearly. And this view is useful for any LVOT lesions. You want to see the flow in the pulmonary artery, and it's also okay view for infundibular stenosis because you are again parallel to the ultrasound beam. And that's what the color Doppler shows is the right atrium, tricuspid valve. You see only the right ventricular outflow tract. You don't see this is inflow right ventricle and outflow. The rest of the right ventricle cavity apex is not seen in this view because you are moved quite anteriorly. Just from the inflow, you're going to some small cavity and then right ventricular outflow. This is the pulmonary valve, and that's the pulmonary artery. So any structure in or obstruction in right ventricular outflow tract can be seen very nicely in this long axis subcostal view. This is the most anterior view on angulating the probe. Let's now go to the subcostal view, short axis views. And then the very first view, which we are interested in, is inferior vena cava, because that's where it's very, very important to know the inferior vena cava collapsibility and hepatic venous flow for differentiating between CCP and restrictive cardiomyopathy, also looking for severity of tricuspid regurgitation, which could show a systolic wave here. So now these two views are very important. This, in fact, is called a bicaval view, where you see the inferior vena cava, you see the superior vena cava. This view I would show you where you see both the wave, and this is left atrium, the interatrial septum. This is where you would see your sinus venosus ASDs. I'll show you the examples. First is IVC collapsibility. You see this IVC, and you see this is collapsible, showing a respiratory variation. And that is an IVC which is dilated and showing respiratory variation. That is a level up on the pulmonary artery pressures or right atrial pressures. And then you see an IVC which doesn't show any variation with the respiration, and it's dilated. Now, dilatation of IVC, we take it as a 21 millimeter, but that's the Western data. We believe 17 millimeter for Indian population is good for making a distinction between dilatation of IVC and a normalcy. Remember, IVC is normally dilated in the patients on ventilators. So you don't make an assessment of IVC dilatation once a patient is on a ventilator. So this is a little angled view of IVC, where you see the IVC and then you see the hepatic vein flow, you see the to and fro, you see systolic up wave in the hepatic vein. This is now becoming a perpendicular, parallel to the beam. You can put the sample here and take hepatic venous flow patterns. Now, this is the bicaval view. This bicaval view cuts the inferior vena cava and the superior vena cava and the part of the right atrium, and posteriorly there is a right ventricle. This is how the bicaval view looks like, and that's how the bicaval view looks like. This is the right atrium, that's the liver, and this is the left atrium. This is the interatrial septum. This is the place where the fossa vallis, and that is the atrial septum close to the superior vena cava, where you would see sinus venosus ASD. and that's the inferior vena cava, superior vena cava. This is the bicaval view, and mostly you would see this is the tricuspid valve, but many a times you see the right atrial appendage here because that cuts through the right atrial appendage also. Now, if you move, now we are moving from the right side to the left side with keeping the probe in the middle. This is vertical. The probe, as I shown you, is the vertical to our abdominal wall with the marker facing up. And this vertical probe is moved like a swept from the right side to the left side. So we were on the right side seeing the IVC. Now we are moving the probe, tilting the probe towards the left side in incremental fashion. Now, first increment we see right atrium, the right ventricle, and you can see a diagram on this side. See the pulmonary valve and see this portion of right ventricular outflow tract again, which is parallel to the beam for a wonderful color Doppler or a pulse Doppler interrogation. And that's the pulmonary artery. Right in the center, you have aorta at the aortic valve level. So this is the view where you see, now look at the en-face view of the tricuspid valve. This is the septal leaflet, that's the anterior leaflet, and this is the inferior leaflet or posterior leaflet of the tricuspid valve. And then this is an RVOT, that's the pulmonary artery, and you see nice pulmonary valve here. And once you put the color Doppler on, you see this is the similar view what we had on a long axis views. And there you can see the RVOT, and again a three-dimensional view giving you a bit of a depth perception. That is an RVOT, pulmonary artery, and then branching further. Now, this is the en-face view of the tricuspid valve. That's the posterior or inferior leaflet, septal leaflet, anterior leaflet. There is a bit of a doubt about the nomenclature of the tricuspid valve leaflets from anatomists, but anyway, you can see an en-face view of all leaflets of the tricuspid valve and a 3D. Again, this is the live 3D. The moment you put live 3D on, you see all the three leaflets of the tricuspid valve in this view, and you can know which leaflet is involved. You move again this probe, sweep this probe from this position to this position. Then in first you would get the LV at the mitral valve, then the papillary muscle level, and then at the apex, exactly like what you would do a short axis views from parasternal, a short axis view. This is the view where you are at the mitral valve level. That's the mitral valve, anterior and the posterior mitral leaflet. They open like this, and this is the LV, and then you have an LV apex. And in fact, LV apex, you can go right up to the apex in case it's not possible to go from the apical windows. I'm going to show you now a couple of cases from a subcostal window so that you know the structures still more confidently. So you are going to see about 100 subcostal views so that it becomes a mental picture to use subcostal views in a proficient manner. Now, this is a liver, and that's the glistening pericardium. That's the pericardial moderate, like kind of a pericardial effusion, right atrium, and then you see the pericardial fluid. The pericardial fluid is not much present in the subcostal window, while anteriorly you see a little larger effusion. Same as if you angle it towards the left ventricle, you see this moderate to large pericardial effusion. You do a 3D, and even on 2D, you did not see any exudates. This looks a clear pericardial effusion. It still may be exudative or transudative. We can't make it on that effusion. But in case you see this, you think it's pericardial effusion. Yes, the difference between the two is that you'll see a lot of speckles here. Do you see a lot of speckles inside? Okay, some tissue. right? And that's the parasternal view. You don't not only see speckles, but you don't see any effusion. Effusion has to start from the posterior because of the gravity. The effusion should be, fluid should be here. This is epicardial pad of fat, the thick epicardial pad of fat, which is again these days pathological, because we believe that that's an inflammatory state which produces increase in risk of heart failure with preserved ejection fraction and even coronary artery disease. So this is an epicardial pad of fat and not pericardial effusion. If you don't believe me, I'll show you both. Now, this is an epicardial pad of fat, and around that is pericardial effusion. So this patient had an epicardial pad of fat, which is kind of a normal thing. The thickness varies. The epicardial pad is a normalcy, happens in everybody. And then you have a pericardial effusion, and this is showing a lot of speckles inside. Pericardial effusion is clear. That's how you differentiate from pericardial effusion. And posteriorly, again, you see the fluid, which is a pericardial fluid. Now, this window is showing exudative. You see the thickening of the pericardium, and you see multiple exudates here. And these are features of inflammatory and exudative pericardial effusion. It can happen in hemopericardium. It can happen in infections of the pericardium. It can happen in uremia. So, or other rheumatological disorder which produces a pericardial. This patient had a tuberculosis, and there was a pericardial thickening. In fact, this patient had features of constrictive pericarditis. You see marked exudates all across both layers of pericardium, the visceral layer and parietal layer of the pericardium. This is the parietal layer of the pericardium. That's the visceral layer of the pericardium. And you notice a lot of exudates. And that 3D again show you spiky appearance on the side of the left ventricle with the large pericardial effusion, and the spikes also exudates on the parietal layer of the pericardium. A little different way of pericardial exudates. You see a thicker exudates in the pericardium, and then you see again thick pericardial sticky exudates. Both mean the same thing. Actually, they're not very different. Patient had an atrial fibrillation, which was intermittent. You see the exudates and the thickening of the pericardium. Again, exudate, the patient converted to the sinus rhythm, and you see these exudates nicely there. The next couple of cases, I'm going to show you various RA masses. The first RA mass, and it's glaring. I don't have to tell you this is the cost of the deep vein thrombosis, a thrombus which has come from the lower limb veins, and this is the cast of a long cast which is folded in the right atrium, somehow fortunately got stuck somewhere here, maybe with the eustachian valve of the inferior vena cava, and didn't go to the pulmonary artery. Pulmonary artery still is small, looks like the patient, this patient did not have features of pulmonary hypertension, so the thrombus fortunately didn't reach its destination of the pulmonary artery. That is where the snake-like or a rope-like folded mass, which is a cast of the veins of the leg. Then the second mass, which I'm showing, is a myxoma. We could not see a clear attachment, though we suspected attachment to be here, close to the inferior vena cava margin, and that is the right atrial myxoma, which is huge. And left atrial myxoma also is very nice to see from the subcostal window. You can see very clear attachment of the mass pedicle, which is stretching on the interatrial septum. So this is the pedunculated mixed echogenicity mass, which is a myxoma. You see another mass in a patient with a sarcoma, and that's the deposit of sarcoma secondaries here. This is close to the inferior vena cava the inferior lip of the inferior vena cava opening, and that's the mass, and that you see the mass in relation to the inferior vena cava, probably in relation to the eustachian valve in the right atrium. Another mass which I showed you when my presentation on image optimization, you see the dilated inferior vena cava, you see this rounded mass, and you see this mass with multiple. And this mass, actually, when we did a TEE, I'm not showing you those images, the mass actually became multiple. There were three. And this patient had hemoglobin of 19 and JAK2 positive polycythemia vera, and with the treatment, this mass actually disappeared. This was a thrombus. So this is another mass which is coming here into the lateral wall of the right atrium. And when we saw this mass, it was coming from the inferior vena cava. Okay, and see it's kind of obstructing the inferior vena cava.
That sound will not come here, no?
Okay, so this is the inferior vena cava mass. So this was coming from the right kidney, because this patient had a clear cell carcinoma of the right kidney, which the mass, it is extended into the inferior vena cava. It is the tumor itself which extends into the inferior vena cava, can go up to the right atrium. Can you mute others, please? Okay. Can you mute? Yes, please. Yeah, keep mute. Now, normal RA structure. Again, once you talk about masses, you should know about normal RA structures. This is the eustachian valve, and you see this eustachian valve. Can the organizer mute Mr. Tarun or somebody from the team? Or Rishi, can you mute all others? This is the eustachian valve. We see on the three-dimensional, this is the normal structure. So this is not a kind of trochard atrium. This is again a mass-like thing, but this is a crista terminalis. You must know these normalcies. Let me show you a couple of ASDs. First thing and very important thing is to differentiate ASD from patent foramen ovale. And the way to do is you have this as now this is the bicaval view. This is the superior vena cava. That's the pulmonary artery. What you see, the superior vena cava entering into the right atrium, and this is the fossa vallis portion. You see this small PF4. And, incidentally, this patient had a VSD, also a muscular VSD close to the inlet portion. Now, for the ASD, you have this T sign. Now, T sign is because of the endocardial overlining on the interatrial, this fossa, and then you get a T sign. It indicates a small restrictive ASD and not a PFO. You see this T sign, a glistening area on the edge of the interlateral septum. So now all PFOs are not benign. Now look at this PFO and look at this video. You see the blue color here? So this is the bidirectional PFO. There is a right to left shunt in the PFO. This patient had an episode of thromboembolic event and had a stroke. And that's why the echo was being done. And this is the reason for the stroke, which we, many a time used to call it a cryptogenic stroke. The reason is that you have a bidirectional flow across the interatrial septum. This is the inferior vena cava, and now this is the large. This is the eustachian valve, large eustachian valve, which is normal. But what you see here is the flow across the interatrial septum. And then you have again a reason for having a bidirectional flow in the interatrial septum. And the reason here is that this patient had an absent tricuspid valve or unguarded tricuspid orifice, increasing the pressure in the right atrium. IVC was dilated, the coronary sinus was dilated. So the pressure, you look at the rudimentary valve, and that is unguarded tricuspid orifice. And there was an ASD which showed a reversal of the flow also. But there's another reason why you can have a reversal of the flow. Okay, the reversal of flow can come. Just give me 1 minute, please. Yes, sorry for the gap. Now this is the right to left shunt, and interestingly, you don't see any pulmonary vein entering into the right atrium here, and that's the reason why you are having right to left shunt here. And you see, this is the aorta, and this is something which is also red. That means going toward this side. Aorta is going to toward the lower limb. So is this going inferiorly. So that means that this was a vertical vein from all the pulmonary veins draining into this vertical vein. Vertical vein was entering into the liver, and from there it was entering with the small obstruction into one of the hepatic veins. So this is a TAPVC of the infracardiac variety. That is something which you would see many a times, and that's very, very important. Please spend some time here on this view. I showed you this was a kind of a bicaval view where you see the superior vena cava, and if this portion is missing here, you see a patient of an RARV dilated, you see increased flow across the tricuspid valve, but you don't see an ASD. Please go to this view, because this could be a sinus venosus ASD, and commonest sinus venosus ASD is related to the superior vena cava. It is said that this is what is called the superior vena cava overrides on the interatrial septum. That's how we recognize superior vena cava VSD on a fecal echo, that the SVC overrides on the interatrial septum. There is a wall which is missing here, and then this is the left atrium, and you see the flow across the left atrium to the right atrium through this. And in case you have the 3D probes, you can use a 3D. And you can, on a 4-chamber view, if you do a good 3D, you still would be able to pick up sinus venosus ASD once you are seeing an interatrial septum and fast. So from a 4-chamber view also, you can see in case you are using a 3D data. Now, this is inferior vena cava related. So this is pretty rare. Now, inferior vena cava sinus venosus ASD is very, very rare, and that's where you see the ASD jet, in fact, entering into the hepatic veins, not only the right atrium. Now you can see a common AV canal defect. You see primum ASD, and you see the flow across the primum ASD. In fact, you see this was the patient of heterotaxy, common AV canal defect, and you can see this one vein going away from the field of view, and that is what is a vertical vein from a total anomalous pulmonary venous drainage, and that's the en-face view from the subcostal view. When you see all the anterior and inferior bridging leaflets, which I think Dr. Vijayalakshmi would be talking about it in her talk later on. But now this is the right ventricular hypertrophy, which I told you is the best seen on a subcostal view. More than 4 millimeter thickness is called a right ventricular hypertrophy. You had a marked right ventricle hypertrophy. Incidentally, the left ventricle also was hypertrophied, and there was no obstruction to the right ventricle. So this hypertrophy was because of infiltrative disorder called Pompey's disease. This patient is on replacement enzyme therapy, and the right ventricular hypertrophy has disappeared. So for the pulmonary stenosis, again, once you have a pulmonary valve, you see the RVOT very nicely. There is no pulmonary valvular obstruction or infundibular obstruction. This is the tricuspid valve end phase fast, and that's the RVOT, and this is the pulmonary valve. You are again parallel. You can take a very nice CW to know the gradient across the valve. That's the patient with the Sys kind of a VSD, multiple VSDs of the apex. But what the patient had was there was an infundibular obstruction here. The pulmonary valve is here, and you get an obstruction here with the PISA. Here, this is infundibular obstruction, which again is very nicely seen on this view. And on a parasternal short axis views, this becomes actually parallel to the beam, and the gradients are not there. That's what I wanted to tell you. Now the gradients are not, so if you try to take a gradient here, your the cursor is not aligned with the flow. It is actually perpendicular. You won't get too much of gradients here. And but once you go to a subcostal view, you see this obstruction here of the double outlet double chamber right ventricle. This is the slight difference between double chamber right ventricle and the infundibular obstruction, because this happens in the mid of the cavity, and that's the pulmonary valve. This is RVOT. This is happening before RVOT. And here you are absolutely parallel to the beam, so you can actually do a very good CV Doppler. And that's another patient where I told you this is anterior mitally flat, posterior mitally flat at the LV level. You angle it slightly so that you get the pulmonary artery, and then you see a muscular VSD, a subpulmonary muscular a VSD, which is opening very close to the pulmonary valve. And thank you very much for your kind attention. I deliberately showed you multiple cases there so that you get more accustomed and used to. And honestly, I believe that today also I learned lots. Thank you very much. So let me check in case there are any questions or something, because I was busy with this presentation, and let me check from my mobile in case we have any questions from the audience. In the meantime, Dr. Satish, are you ready, sir?
Yes, Dr. UP, I'm ready. My
right.
slides are on.
Yes, I would do that. Let me, I have a couple of questions, so let me go through those questions here. Yeah, there's one comment that subcostal view, mainly we use it in ICU or for IVC, but can you give some insight for IVC volume status in patients on ventilator? I think I have a YouTube video on assessment of pulmonary pressures, and there I did mention IVC assessment in patients with the ventilator and patients without ventilator. You can check on that. In this webinar, yes, this webinar is available, would be available for quite some time online, and you can always go browse slow speed, fast speed, and specific areas. Dr. Kajri Chakravarti says how to assess RA and LA appendages during segmental analysis in TE or TTE, which views to be.
I'm going to do that.
Yeah, I think yes. So then wait for a while. Dr. Vijayalakshmi would you take you through. Her talk is after Dr. Satish Govind has two talks, and thereafter Dr. Vijayalakshmi would present her talk. Is that okay, Dr. Vijayalakshmi? Is that fine with you? All right. Okay. So Dr. Satish is a wonderful human being and a very good friend, and he wanted me to have this webinar in Punjabi, but I said, let's not do it. Too many people know about. Anyway, Dr. Satish, go ahead.
Yeah, maybe after Satish's one talk, I'll talk and again he can do the next one.
All right. Satish, is that okay with you, sir?
Yes, please. Yeah, I
All
think
right.
starting
All
on
right.
a serious note, I think thank you, Dr. UP, for this invite, and it's wonderful to be a part of this learning exercise, and I think it's a great initiative. So let me start off, and apologies for the earlier disruption, it was beyond me. So the whole idea of this webinar is the keywords which I have seen is the fundamentals and foundations. So basically, it'll be focusing on those issues, and the two important views which is the the most important views I would say in terms of the echo would be the long axis and short axis, and I'll be going through that. Now, one is just to understand some simple sort of terminologies and the axis. So this is just going back to our, the very essence of how the basics starts. So we have the body long axis, and then we have the heart, which has got its own long axis. So it's more oblique, and this is how it looks like in the cavity. So this is something which we should be aware. And then what we are looking at is the sagittal plane and the transverse plane in this particular presentation. Then the long axis itself, I'm going to initially focus on the acquisition and then the echo anatomy. So when we are looking at the long axis, we have these various terminologies. There is this conventional way of saying parasternal long axis, plaques, P-lax. So they're all one and the same. And in this long axis, we have these additional views, the modified long axis, where we have the RV inflow, RV outflow, and then the right parasternal long axis. And of course, there are any number of off-axis views. We have to utilize any view which gives us the information which we want. So don't hesitate to go a little out of the way to get these views. Now, the obtaining the image, first and foremost, is the orientation of the probe. So this is the long axis, and you have the sternum there in the middle, and 1/3 of the heart is on the right side, and 2/3 is on the left side, and a good chunk of the heart is behind the sternum. So it's always going to be a bit of a challenge. And looking at the long axis, this is how the orientation of the probe is going to be. And typically, we would like to see in an elective cooperative patient, we would like to see the patient in the left lateral. And this is, the idea is to bring the heart away from the sternum as much as possible. It should be close to the probe. And we also should encourage the left upper limb to sort of be stretched up as much as possible so that we open up the intercostal space and maximize the window that we are able to see. Once this is done, then the comfort of the operator is there, and then the probe is put on the chest, and you see that index marker which points towards the right shoulder, and and it's important that we connect the ECG leads anytime an echo is done. Now, once the echo is started, so you do a quick sort of massage, sort of you go around that area where you really want to sort of look at it, and once you get a good image, that is where you fix the probe, and then you get your image, and from here onwards, you start your measurements and looking at various structures. Now, when we are acquiring images, just a few tips so that, it's always better that we acquire in the right manner so that we can always revisit these images for whatever purpose. So try and avoid acquiring images with one beat. So it's always good to acquire images in 3 beats. And when we are looking at good images, we don't want the sector width to be too wide, nor should it be too narrow. So we should optimize. So the idea is that we need to see the structures, what we really want, and then we want to get a good frame rate. So if there is a good frame rate, that means we have good images. And that is when our utilization of whatever we are seeing is maximized. So widen the sector only if it is necessary. For example, if it's a dilated cardiomyopathy or you're looking at pericardial effusion, then you're forced to sort of widen the sector width. It is quite okay. Now the depth also. So again, we are looking at good techniques, good tips. So we should optimize the depth. So we should not have too much of depth where the structure is too far away and we have unwanted space below. And then we sort of don't want to lesser depth also, cutting off some structures where you see that the descending thoracic aorta is missed out. So ideally in a good parasternal long axis, classic one, so the depth should be optimal. So where you see the descending thoracic aorta, which is a few centimeters below the posterior wall, and that is how it should be obtained. Now the gain itself, so we don't want to increase the gain. The thickness of the wall increases, the thickness of the leaflets go up, and you might not sort of catch some small masses or some other structure. So we have to make sure that the gain is neither too much nor too less, so that we don't sort of distort findings. So again, the key word is optimize the gain, so it has to be optimal. Now, the purpose of the 2D is that any structure, the principle of 2D is any structure which is perpendicular to the ultrasound beam, it comes out very nicely. So anytime when you're seeing a structure, so make it as perpendicular as possible, and it gets highlighted very nicely. So you can see that you have the borders also sort of, which gets fuzzy as you sort of, go away from the perpendicularity. So be as perpendicular as possible to any structure, especially in the Parasternal long axis. Now, when you are doing the Parasternal long axis acquisition, so you get to have these various challenges, so depending on the windows or depending on the skill or the novice. So you have the image which looks in the upper intercostal space, that's how it will look. And as you keep going down the intercostal space a little lower down, the LV starts to sort of become a little more sort of vertical, more oblique from horizontal position. So that means if you see something like this, try to go upwards and try to get the image which you see in the upper intercostal space over there. And the initial image, what we do is we always get this, and then we sort of straight away start looking at the valves and a little bit of the LV. And but the idea is that we need to maximize whatever we are seeing. So you can use the image. So there's a tilt option which is there with all the machines. So without losing frame rate, you sort of push it on either side, you tilt it back and forth. So on this side, you can see that you're primarily looking at the LV. So you're still utilizing the best frame rate. And then you tilt the other way and you look at the aorta. So with this, you sort of get all the structures in the best possible sort of frame rate and the clarity of the image. Now, when you're looking at the valves as such, you need to use the zoomed view. So this is because they are smaller structures, there are small findings which may be missed out, small measurements. So always develop a habit of looking at the aortic valve, LVOT with a zoom view, and again with the mitral valve also to look at the closer to the finer points of the mitral valve. Now, there are some problems as far as getting images are concerned. So this is something which we have to accept. So one is the patient. So anytime the patient has got a particular problem, we can't change that abnormality or the patient habitus. So we are sort of, we have to adjust to it. So for example, if there is a lung which has inflated, for example, in a COPD, then we have to accept it. And then we also have skeletal deformities. We have elderly people with a lot of calcification, chest deformities, so sternal deformities, very muscular individuals with a lot of muscles. So again, here the image won't be so good. So there's not much we can do. And all the more when you have a moving organ, it makes it more difficult. But what can be done is, again, these are operator dependent. So this is again dependent on the hand skills and the knobs utilization. So based on this, you can get a better image, which is operator dependent. And again, the machine also, if you have a low-end machine, obviously the images are not going to be so good, and the high-end machines will provide you better images. So these are sort of factors which you have to keep in mind. Now, coming back to the long axis. So this is how the long axis looks like. You have the outlet, which is in a different plane, and then you have the apex. So the LV apex to the outlet goes in a different direction, while the LA long axis goes in a different direction. So this is just a simple sort of understanding of how these chambers, they have their own long axis in slightly different directions. So when we are looking at individual chambers, we have to adjust to this, and we should be aware so that we get better information and greater accuracy in our measurement. And also be aware that the septal curve, which is there, the interventricular septum, so it has this natural curve of going towards RV. Anytime this septal curve is lost, that means that there is a problem on the right side, either in terms of volume or in pressure. So be very careful about it and be observant about it. So this is very subjective, but this has to be confirmed with various other findings later on. Then in the long axis, you're also going to look at the motion. So you have the circumferential fibers, which are more prominent here, unlike in the apical views where you see more of the longitudinal fibers. So here you see more of the circumferential fibers. So the radial inward motion is much more. And then the texture also. So we should sort of optimize the gain in such a way so that we should, as much as possible, look at the myocardial texture. So for example, in infiltration, it has got a different texture. We have fibrosis, there's a different texture. So we should be aware of these terminologies also. Now, how to interpret this? You have this echo anatomy. So you have the probe at the top. So the one which is closest to the probe is anterior, and the one farthest is the posterior. So that's how the anatomy looks like. And towards the aorta is superior, and towards the apex of that is the left ventricle, is the caudal or the inferior part of the body. Now, the left ventricle. So let's take the left ventricle itself. So you have the chest wall at the top, and you have the septum, the interventricular septum. Specifically, this is the anterous septum. So not just the interventricular septum. So this is the anterous septum. So here it is divided into the muscular part, and you have very small, tiny membranous septum also. And on the other side, you have the posterior wall. And this again has got two sort of namings. So it has a mid and basal segment, and you have the cavity in the center over here. So this is about the left ventricle. And again, part of the left ventricle, you have this very short sort of outlet, which is about a centimeter or so. So this is the left ventricular outflow tract. So this constitutes the left ventricular chamber. Now, the measurements part of it. So the measurements, again, you can either do it in 2D or M mode. So these days, it is more recommended that you do any measurement with the 2D. And this, again, we need to know the normal values. So we are looking at the chambers in terms of size. So whether the cavity is dilated or not, thickness, whether it is hypertrophied or not, and the motion, whether it is good function, normal function, regional function affected. And you have these various numbers. So you have, that is easily obtainable on the internet. So you can look at these numbers, what are the normal ranges. And when it comes to the M mode, we have to be very perpendicular. So that's why there's a limitation of the technique. So that is why we have to be careful about it. So what do I mean by this M mode? So when you take the M mode, so I have one slice, and that slice is equal to measuring. What we are doing is we are doing one measurement, and we are trying to interpolate the entire, whatever findings we get on the entire LV. So we have to be very, very careful. That's why there's an inherent problem of the M mode itself. So if you look at it, so you have the blue line. So most often the technique is, very carelessly done many a times. So when you don't do the perpendicularity properly, so you get a bigger LV size fallaciously, and you have the thicker, the walls also become thicker. So you end up giving, a patient who's got a normal size, a slightly bigger size, or vice versa. It goes back and forth here. So the ideal way is to cut it perpendicularly and make sure you cut it at the tip of the leaflet so that you get accurate measurements. So the same thing with the linear measurements of the 2D also. So again, an oblique cut is not good. And again, the mid-cavity cut is not good. So what is recommended for the sake of standardization and for reproducibility is that whatever measurements we do, it should be at the tip of the leaflets. Now, these are various methods which are sort of available to us in terms of how to get the numbers. So you have the M mode, and then when it is dilate, it works nicely if it's done properly in a normal person. But once the LV starts to change in terms of dilatation, in terms of thickening, wall motion, then all these, whatever the calculations based on a certain formula which assumes something, it's a problem. So it's also a linear measurement. So it is generally sort of advised, recommended for new people who start on echoes. But people who are doing routine echoes, it is better to avoid M mode itself. So this is something which you have to be careful because of its inherent problems. So what is the other method of looking at the LV function by M mode itself? Again, this is for very basic ones. So this is more focused on people who are not really tuned into routine echoes. So people who are doing POCUS and other specialties. So here again, there's an E-point septal separation. So this is a very old method. So this can also be used. So we are looking at the tip of the mitral leaflet point, and then you're looking at the closest point of the septum. And the more wider it is, more dysfunctional it is. So this is again one other method, very low sensitivity. And then you have the fractional shortening, again, the shortening part of it. So there's again a calculation here. So again, it's a linear measurement. So it will be very fallacious when again the LV sort of changes its geometry. So these are parameters which we have to sort of be very, very aware. They have a lot of limitations, and we have to be very careful when we are using it. Now, let's start looking at the other measurements. So now when we are looking at the LVOT itself, so ideally it should be a zoomed view. So the typical length of the LVOT is somewhere around 1 to 1.5 centimeters, and the width is approximately 20 millimeters. So it is variable depending on the height of the patient. So this is again how to measure it with the aortic valve open and a zoomed view. Now, from left ventricle, let's move to the left atrium. So you have the left atrium here. So you have the anterior wall of the left atrium, and you have the posterior wall, you have the superior part. So you have to keep this anatomical landmark so that when you see an abnormality, you sort of say that it is towards the anterior part of the LA, or towards the posterior, or towards the roof of the superior part. So these are anatomical terms which you should be aware. Measurements, again, this is a very old measurement, has a lot of problems, but we still use it quite widely. So again, it is at end systole. So you have this leading edge to leading edge. So you have you have to make sure that it is perpendicular. So no oblique cut should be there, just like the LV itself. So M mode is again not recommended because again of technical sort of limitations and the way one does it. So ideally, what is suggested, it is better to do it on the 2D image itself. So this is the how to size the LA. And then looking at the right ventricle. So now let's move on to the right ventricle. You have the chest wall over there, and what you see at the top is the right ventricular wall, the first wall, just below the chest wall. And then you have, once in a while, you might see the moderator band coming over there. So that can again come in the way of some measurements. So be aware that the moderator band can come, especially when it becomes a little more prominent and thicker. And then you have the tricuspid valve also. Sometimes it will it'll be seen sort of bobbing back and forth over there. So this is typically not the true RV here. So this is the RVOT at this point. So even in the RVOT is more of the proximal RVOT. So we should be careful that this is just a part of the RV which you see, and this is the proximal RVOT. How to sort of measure? So very low sort of in the measurement sort of parameters, it comes a little lower down because it's a little variable. So typically these are the numbers. And one can also look at the RV-LV size ratio, especially we are looking in terms of pulmonary hypertension. Once the RV-LV size starts to equal to normal, that means the RV is beginning to enlarge. And that is when, this is part of the pulmonary hypertension parameters, the likelihood of pH over there. So this is how to look at the RV. Now, the RV itself needs to have its own sort of measurement in terms of RVH. So a little difficult because it's very close to the chest wall, and many times it's such a thin structure, so you may not be able to see it. But sometimes subcostal is not there, which is usually recommended for RVH. But you can use it if it is possible, if the window is good, and we have to zoom it and make sure that we do it correctly. And this is the second approach in terms of looking at the right ventricular hypertrophy in terms of RV thickness. Now, from the chambers, let's move to the mitral valve. So you have the mitral valve. So again, here you have the anterior mitral leaflet and the posterior mitral leaflet. And in a classic view, it's always going to be the A2, P2 segments, which you see here. If you're tilting more towards the RVOT, you're more likely to get the A1, P1. And if you're moving towards the RV inflow, you're going to get the A3, P3. And towards the RV, you also have this aortomitral curtain. Towards the mitral valve, you have this aortomitral curtain and also the continuity. So we have to look at this very carefully because this is an important structural area where it's a lot of importance. And then we look at the mitral valve. So any valve, we have to look at mobility, thickness, calcification, and also the subvalve. So subvalve, we have to go a little off axis and focus a little more so you have a better view. So here you can see that the papillary muscles, chordae, when they are normal, very difficult to get because they are very thin structures, and you get to see it better when it starts to get calcified or fibrosed. And this is, again, to look at papillary muscle in terms of thickness, any rupture, any other abnormality which you see over there, and even chordae, redundant chordae, ruptured chordae, all these things. And again, in the parasternal long axis, coming back to the mitral valve, so one can do measurements of the thickness. So typically the measurement is at the mid diastole. So making sure that you don't sort of measure a nodule over there or a chordal attachment. So make sure that you do it correctly. And then again, length of the leaflets can be measured here, both the AML and PML. And then again, the annulus diameter. So this again can be measured. It gives you the anteroposterior diameter of the mitral annulus here. Now, the mitral valve M mode, which is an old one, has got very limited value. So we sort of, it's a very familiar friend, but very low value here. Just I'm showing it just for the sake of showing it. But the use of it and the value of it is very low. Now, from mitral valve in the parasternal long axis, let's move to the aortic valve. So aortic valve, you have the right coronary cusp, which is a constant, which you always see. That is the top part of the image. And then you have the other cusp. Typically, it is going to be the non-coronary cusp. But once in a while, depending on how you tilt your image, it can also be the left coronary cusp also. So be careful about that. And then you have this coaptation zone over there. So there are a lot of other sort of measurements that can be done here. Again, just like the mitral valve, you'll be look at mobility, thickness, calcification, and the cause for and any other abnormalities, and also the regurgitation part of it. And the aortic valve M mode has its value in a very limited way. One can look at sort of fluttering, and then the way you see that open box, that means the cusps are open, and then you see a single line, that means the cusps are closed. And again, based on the bicuspid trileaflet tricuspid valve, so that attachment can be in the center or it can be eccentric. So it gives you some information, but it is in a limited way. Now, from the aorta, let's go to the aortic root itself. So the aortic root constitutes the annulus, you have the sinus, and you have the ST junction. ST junction is the junction between the ascending aorta and the sinus. So that is why it is called as the ST ridge or the ST junction. So here we are looking at the size, we are looking at calcification, any other abnormalities. And typically the annulus is in systole when it is measured, but when it comes to the aorta, everything is measured in diastole. So you have to make sure that you do it so that we try to be as close as possible to the other imaging modalities. So you have the right sinus over there, and the other sinus can be non-coronary or the left sinus over there. And then you have the junction between the sinus and the ascending aorta. So that is the tubular ascending aorta. So that's the ST junction over there. And once in a while, you can sort of actually make out the right coronary artery over there. So that also can be seen. So when you see it, utilize it. And for whatever reason you see it, for the value it gives, you can utilize it. Aortic root measurements, again here, so you have these multiple measurements, the annulus, the sinus, the ST junction, and the ascending aorta. So a lot of measurements can be obtained from this view, provided you do it in the right way. And it is sort of, you have these different numbers which are there. And this, again, is available very easily in terms of reference. There are various values, the tables which are available on the net. Now, also, what is also possible is to look at the descending thoracic aorta. You always, generally in most patients, you see this very circular sort of structure. So that is the en-face view of the descending thoracic aorta. A little bit of a change in the probe, you can actually sort of get to see a little bit of the course of the descending thoracic aorta. This is the upper part of it. So if the window is good, we can utilize it, especially when you are looking in terms of any aortic abnormalities. So this can be used, quite easily. And this gives you size or any other sort of information that is available. You can also put some flow. May not be so accurate in terms of flow, but definitely 2D wise, I think it can be used. And other structures which can be seen in the parasternal long axis, if you go a little closer, so you get the left atrioventricular groove, and here you have, most of the time a little prominent fat pad over there, and within this fat pad you have the left circumflex artery. So sometimes you have these abnormalities which you can visualize in terms of the circumflex. And also the coronary sinus is also very close by. So when it dilates, it sort of becomes really prominent visible. So we should be aware that the structure is over there and that equilucency is because of a coronary sinus. And though we are told that the oblique sinus is there in that particular area where the pointer is marking. So this generally gets to be seen when there is pericardial effusion, and you get to see the reflection a little better. So this again, just to show you that where you can see the oblique sinus over there. And as Dr. UP was pointing out, so you have the epicardial fat and the pericardial fat also. And this again has got a very granular appearance. And the epicardial fat is close to the myocardium. So it keeps moving, and that is with every cardiac cycle. It is not echolucent. Pericardial fat is also granular, but less likely to move. So this again is, with two ways of looking at it. So commonly when you don't optimize the gain properly, it is mistaken for pericardial effusion. So one has to be careful about this epicardial fat. Now, the pericardium itself, again, we sort of had to reduce the gain so that it's a highly reflective structure and is the most reflective actually. And once you reduce the gain, it starts to increase in its brightness, and that's when we can do the measurement. So again, somewhere around 3 to 5 millimeters is the normal thickness. And again, we can look at any pericardial space. And if there is a fluid which is not seen in diastole, that means it is it's not abnormal. So we have to be careful about it. Again, pericardial effusion, you see the aorta over there. Anything anterior in terms of the effusion, so that is pericardial effusion. Anything posterior to the ascending aorta, the descending aorta is going to be the pleural effusion. So these are sort of very old sort of thumb rules and findings which we should be aware of. Now, switching to the other views. So we have this RV inflow view. So here you can see both the RA and the RV here, and you have the tricuspid leaflet, and we have the anterior tricuspid leaflet and the posterior tricuspid leaflet. If you're a little careless and you end up showing a little bit of the LV on the other side, so it will not be the posterior tricuspid leaflet, it will be the septal tricuspid leaflet. So be careful about it. So you have to take away the LV completely, and only then it becomes a posterior tricuspid leaflet over there. And then you have these small openings, especially when they become abnormal, they get to be seen. And sometimes you see these two flows. You have the coronary sinus and the IVC over there. And once in a while, you get to see the SVC flow coming from the other side. So most of the times, you may not be able to see it. And then the other sort of RV flow, modified RV is looking at the RV outflow. So this is again, we tilt it upwards, and then you get to see the RV outflow. And that is the distal RVOT, what you see over here. And then you see the pulmonary valve also. So pulmonary valve, if it is good, the sizing is fairly accurate here. So it is recommended that you can use this pulmonary valve, the annular sizing here. And so this again is the outflow view here. And again, any sort of parasternal long axis, we go through this sequence of putting on the color. So we look at the mitral valve, look at the aortic valve, and then we put it across the interventricular septum. So look for any abnormalities over there. So whatever, whether it's a VSD or a VSR, and then any ASAR, all sorts of abnormalities. Color is very helpful over there, as we all know. Now, the other window, which the other view is the right parasternal long axis. So this is usually sort of meant for aortic valve. So because of the alignment which it provides in terms of the Doppler alignment and the gradient that it provides in terms of accuracy. So when you have it, when you're having an aortic stenosis and the other views are not so good, or even if the other views are good, and you should always make it a point to look at this, because the best gradients always come from this. And if you get a good view, the best gradient, the highest gradient, if you get this, that means this is the most accurate one. So here you have to turn the patient to the right side and then go in the direction of the aorta over there. Just tilt it with the index marker, as you see over there in the photo, which points upwards, and you get to see the flow, and then you do the gradient measurement. Now, a few pathologies here. So this is an LV which is dilated, and again, the sizing has to be done. And if it is more than that, we say it is dilated, and you have these abnormalities. So you have a very shiny sort of antoseptum over there. That means it's a scarred one. So there's a patient with coronary disease with a scarred septum over there. And here it is an LA which is dilated, and the mitral valve is not opening valve. So it's a very pliable, restricted mobility of the anterior mitral leaflet, and the PML is not moving. So suggesting that it's a pliable AML, and it's mitral stenosis over there. And the aortic valve is opening well, so not much of involvement there. But the key finding here is the very big LA which is there, and the measurement, anything more than 55 millimeters, they have a higher risk of atrial fibrillation. We look for any thrombus, any other masses which we sec and other things, we look at it when an LA is dilated. RV dilated, you see that the RV sort of increases in size. It dominates in terms of the LV size, and the curvature of the septum, you can see that it is now pointing towards the LV. So that means the pressure is high. There is increase in the RV size. So this is something which we have to be aware, and also make sure that if the window is good, you can also look at any RVH in the near wall of the near frame in the near part of the image. And the other one is looking at abnormalities. So you have the hypertrophic obstructive cardiomyopathy in terms of LVH. So you have the various abnormalities. You have the SAM over there, and this again can be utilized by M mode, and then you can put color. Look at the regurgitant jet in the LA over there. The MR, is typically posterolateral in terms of hypertrophic cardiomyopathy with an LVOT obstruction. So this again, more severe the LVOT obstruction, more severe will be the MR over there. And if the MR is in some other direction, that means that there's an intrinsic leaflet abnormality, and we should try to look for any prolapse or any other abnormality over there. And again, this is just to show the direction of the jet and the turbulent flow as it courses along. And the SAM, which you see over there, is quite severe over that point. And you also get to see the ventricular septal ruptures, as you can see here. So you have to go a little off axis, where you have this acute thinning, and you can see the flow over there. So included even the apical view, but you can also see it in the long axis view also. And then you look at the aorta. So you have these aortic dissections. The echo is not sort of that great. It always has this, the artifacts which sort of misleads you. But when it is seen very clearly, it can be of great help, and you can have an immediate diagnosis, especially with the clinical presentation. So typically there is the flap, and you know that it's a type A. So we look at where the flap is arising, at what level, and where is the entry point into it. And then again, if it is very close to the aortic annulus, there's going to be a little bit of malcoaptation of the leaflets, and we are going to be careful about looking at the AR also. So we will look at it. And also within the false lumen, there is going to be a layering of thrombus. So that also can be obtained, not in all patients, but in whenever the window is good, and if it is sort of, nice findings which you see here. The other points which you can see are the calcific annulus and the masses. So you can see that you will see very big calcific masses over there. So very sort of pointed ones. So very prominently. So you can see that this is a really big one. So this is like a caseum over there. And then this can be seen both in the short axis as well as the long axis. So again, lesser amount is typically more of mitral annular calcification. So you can see that in the short axis, it sort of courses just behind the posterior mitral leaflet. So that is posterior mitral annular calcification. While in the long axis, a really big one you see over there, that is the caseoma, which is seen over there. So these are sort of findings infrequently which you come across. Mitral valves, examples of the mitral valve prolapse over there. So you can see that the tip of the leaflet still points towards the left ventricular apex. So that is the MVP. But once it points in the direction of the left atrium, so that means it's a flail. And also we look at ruptured chordae or any vegetations, as you can see over here, which has caused this particular problem in this particular patient. So any number of abnormalities. Aortic valve, again, sort of we look at it very closely. We zoom it, look at the calcification, look at the LVOT, and look at the annulus, or how much of calcification is there, what is the mobility. So you can see that here, and also looking at the left ventricular hypertrophy, and you can also see that there's pericardial effusion. So a lot of findings can be obtained from this point, and also MR can be seen in many patients with severe aortic stenosis. And MS again, so we are very familiar with this. So the restriction of movement, and then what is called as for the new people. So somebody who's new, so we use this hockey stick appearance. But typically the doming appearance, restricted PML is the one which tells you that it is MS. And then you have a lot of calcification, which you can see in some patients. You might come across this. And the pericardial effusion, again, once the pericardial effusion is there, so the findings will be, if it's seen on both sides, more likely to be circumferential. And if it is seen on one side, it is more of localized. It can be loculated, and we have to look at the effusion. Are there any strands, any deposits within it? And is it causing any tamponade? And also the size of the effusion, how large, whether it is mild effusion, less than 10 millimeters, 10 to 20 will be moderate, and more than 20 will be large effusion. So we can quantify it. So this is how the pericardial effusion looks like. And you can see that it is in front of the descending thoracic aorta. So that is more likely to be a pericardial effusion. And this is to look at the mitral regurgitation, and then again masses in the left atrium. So here, any dilated LA, you have the thrombus over there. So typically any mass in a dilated LA is more likely to be a thrombus. And again, you have to sort of look at it carefully. If you think it is other than a thrombus, there are many other masses. So then we need to sort of look at other additional imaging modalities, and there are various abnormalities. But just to show you an example of how masses can appear within the cavity. And a few sort of techniques which should one should develop. So if one is wanting to look at the respirophasic findings, we need to slow down the sweep speed and bring it down, so as low as possible. And we want to look at these findings. You can see those arrows, which tells you with every respiratory, inspiratory change, expiratory change, you see these up and down motion. So use the sweep speed and reduce it if you want to look at respirophasic findings. When you want beat-to-beat findings, you might have to increase the sweep speed. So you want to look at the fine sort of happenings in every beat. So for example, these early diastolic movements were paradoxical septums, so increase the sweep speed. Now moving on to the Parasternal short axis view. So again here, the acquisition in the echo anatomy here. So again, the terminology is Parasternal short axis, and you have this P sacs and sacs which we use. And here it is divided into high Parasternal short axis, and then short axis at the mitral valve level, at the papillary muscle, and at the apex. And of course, we have the off-axis views, any number of off-axis views of any utility. And here you can see that the probe is turned the other way. Now it is towards the left shoulder. So it is cutting right across the left ventricle here. And again, the positioning in an elective patient. So bring the heart away from the sternum, left lateral. And again, the same sort of technique as for Parasternal long axis. And if you're not getting a good short axis, you can sort of make the patient go steep left lateral and push the patient as forward as possible so that you try to get the LV away from the sternum as much as possible. And once you have this sort of, you do this rotation, so you can see that the probe is turning from the right shoulder. Now it is pointing towards the left shoulder. And then based on that, once you get a good sort of view, so you sort of get your position there and you start your imaging and you start your further investigation from here onwards. And again, same technical sort of advice. So make sure the depth is good, gain is good, sector width is optimized. So everything should be optimized as much as possible. Increase it only in certain scenarios where you feel that it is going to give you some value. And again, we have to make sure that the LV is as circular as possible. And anything which is oval, that means you're not getting a good short axis. So that means you're somewhere in between good short axis and apical 4-chamber. So that means you're a little off axis. So you have to sort of make sure that it is as circular as possible and not oval here. And if you get an oval one, so try change the position a little bit, make the patient go a little more steep left lateral, and this may help you. So just be aware of this. Otherwise, your wall motion, your whatever findings, you'll be sort of locating it in a wrong manner. Now, again, orientation here. So one on top is anterior, one on the other side is lateral, and opposite to anterior is posterior medial. So this is again to sort of localize any findings and the various sort of structures. So this is for orientation. And also it would be a good thing to sort of look at myocardial motion. So most of the times when we sort of look at it, just a quick sort of, anybody can do it on any machine. So if you look at the base, so typically it goes clockwise, and that is a basal rotation. That means it's a very sort of healthy LV, which is doing well. Mid, you don't see much of rotation, but you go to the apex, it goes in the opposite direction. So that is anti-clockwise. So anybody with a good apical rotation and a good basal rotation, typically the LV is sort of healthy and doing well. Once the LV starts to deteriorate, these rotations starts to sort of lessen or sometimes totally disappears. And then you know that you're dealing with abnormal LV over here. And then again, we are going to use the short axis to look at the inward outward movement. So you have this systole diastole over here also. And then the RVOT, so you look at the measurements. So let's start in a methodical way. So we look at the RVOT at the top. So you have the proximal RVOT, you have the distal RVOT, and then you have the inflow at the tricuspid valve level. And then we put the color flow, look for any abnormalities over there. And then we do these measurements. We have these various numbers here at the end diastole. So we have the proximal and distal RVOT. And based on this, we say it is abnormal and normal. So this is how the RVOT is assessed. And then next, let's go in an anti-clockwise direction. So after the RVOT, so let's go to the tricuspid valve. So here again, the tricuspid valve, you can, what is constant is the posterior leaflet, but the septal leaflet and the anterior leaflet closer to the aorta, that is variable. So always the posterior leaflet is a little more constant, but here you can have the anterior and septal leaflet, but it all depends on how you hold the probe. The other leaflet also can happen. So here you're looking at the flow and you're looking at any TRs and all the abnormalities across the tricuspid valve. Next, we look at the RA. So any abnormalities here. So for whatever reason, very limited view, but it does give you some, sort of findings in terms in a different angle here. And then from the right atrium, so going in the next structure, which you see is the atrial septum. So any PFOs, ASDs, aneurysmal septums, all this is looked at. And when you put on the color, you look at the SVC on the other side and the right upper pulmonary vein flows on this side. So you get to see these two prominent flows. And again, based on the tilt of your probe, you can get to see other flows also. But usually you get to see these two big flows, and you sort of, look at for any abnormalities here. And then going towards the left atrium. So left atrium, again, you look at it in a cross-sectional way. And most often, in a healthy person, you typically won't see the left atrial appendage. But when you see it, sort of, this is how it looks like. You can see like it's a long finger-like structure. And immediately below that is the left superior pulmonary vein. And the prominent structure is the comedian ridge. So make sure that you don't mistake this for some abnormal structure over there. So in some people, the comedian ridge can be quite prominent over there. So this, again, just to show you how the appendage looks like, the comedian ridge and the left superior pulmonary vein. And if you put the color, you'll see that the flow will come from the superior pulmonary vein. Now, from the left atrium, so let's go to the last part of the circle. So we go anti-clockwise. Now we go to the pulmonary artery. So we are looking at the pulmonary artery in terms of, we look at the bifurcation over there, and then typically we see more of the right pulmonary artery and less of the left pulmonary artery. And then we can do these measurements, especially of the right pulmonary artery and also the main pulmonary artery. So this is looking at the pulmonary artery here. And the last part of it is looking at the pulmonary valve. So again, putting on color, looking at PR, any abnormalities here, stenosis, all that is obtained. And then we can look at various other measurements in terms of parameters here when you put on the Doppler over there. So that itself is a big sort of topic in its own way. But this is how you sort of end up looking at the short axis at the high pass and short axis. Now, moving away from that, so just before we go a little lower down, the final one is to look at the aortic valve. So that's right in the center. Always go for a zoom view and look at the aortic morphology. So you typically have these three cups over there, and we also get to have a good idea of how the annulus looks like. So there's an on-fast view, and then you get to see the sinuses, the mobility of the leaflets, the thickness over there, and any sort of flow abnormalities also you can look at it. So the RCC is right on top next to the RVOT, and then you have the LCC, which is close to the appendage, and then you have the non-coronary sinus, which is always sort of in a normal person, it has a relationship to the interatrial septum. So this is how we sort of identify the sinuses. And when you're looking at morphology of the aortic valve, it is always better to sort of see it in open position so that we make sure that we don't mistake a raphe for a tricuspid leaflet, and otherwise we will sort of end up saying that a bicuspid looks like tricuspid. So make sure that the leaflets are open over there. And then in good windows, but in children it's better seen, but in adults it may not be seen so well. So you have the left coronary artery, the left main, which is seen over there. So again, around 3 o'clock, 4 o'clock position, and then you have the RCA somewhere around 10 o'clock, 11 o'clock, and the LCA is better seen, the left main, and you can sometimes track even the LAD and a little bit of the circumflex also over there. Now coming down, so we look at the LV at the lower level. So you have the mitral valve level over there. So on the lateral side, you have the lateral commissure, and on the medial side, you have the medial commissure, the posteromedial anterolateral commissure, and then you have these various segments of the mitral leaflets. So you have the A1, A2, A3. So typically the A1 is on the lateral side towards the appendage, while the A3 is towards the medial side towards the tricuspid valve. So that's how the segmentation is done for the mitral valve. And when you come to the mid-papillary, this is the anterolateral papillary muscle. So it's got a dual supply. So less abnormalities in coronary disease. That's the posteromedial on the other side. So more likely because of its single supply. So the ruptures, the MRs are more likely to be seen when you have the posteromedial papillary muscle. And you can also look for any hypertrophic papillary muscle in hypertrophic cardiomyopathy, accessory papillary muscles. So a lot of abnormalities can be looked at, and also caudal rupture. All these can be seen. Apical level, so you don't see the papillary muscles. Moment you take away the papillary muscle, that becomes the apex. So a lot of apical abnormalities can be obtained. So here, whether it's a clot or an aneurysm or non-compaction, a lot of things can be obtained at this point here. Then at the mitral valve, also keep a close look at the septum also. So you have the anteroseptum and the infroseptum, and then the RV itself. So at a slightly higher level, you see the anterior and the inferior wall of the RV, but you go to the sort of mid-level, you're more likely to see the lateral wall also. So when you're at the mid, so the RV, which sort of curves at the top, it has an anterior, lateral, and inferior. So very limited sort of use, but whenever you have a coronary disease, sort of you can try and localize where the hypokinesia is, and if you want, you can localize the artery over there also. Now, just like in long axis, again, you can get epicardial fract and confused with the pericardial effusion. So it's again the same findings, granular appearance, and make sure that you don't mistake it for a pericardial effusion over there. M mode of the short axis has sort of been in the publication, but not really recommended because you don't know where you're really cutting. So again, the problem with M mode is a linear cut, as I told you earlier. So this again is very low value. So I would, in my personal opinion, not a good idea to use this because you don't really know where you're cutting. So when you're in the short axis, are you cutting at exactly at that point, or are you away from it? You're not really sure about it. And it can be oblique also. It's not very reliable. And then very low value. So this could be more sort of useful when you don't have any other sort of views and you think that this can help you. So you can have this just looking at the area of the left ventricle. So you can come to some finding about how the left ventricular function is. But it's very, very low in the list of looking at LV function. And that's called the fractional area change. Look at it from the short axis view. Now, the other important finding which we have to look at is the short axis in terms of coronary disease. So here you have the coronary arteries. So you have the left side, which is divides into the circumflex, and then you have the left anterior descending, and you have the RCA, which goes that side. So let me take the LAD here. So the LAD starts in the middle, it goes down, and it gives the perforators to the anteroseptum, and then you have the diagonal, which goes to the anterior. So that's a large part of the area as far as the LAD is concerned. And when you look at the circumflex, you have the OM and OM2 as you go across the lateral and then the posterior or the inferolateral or the anterolateral wall, the terminologies. And when you come below here, you see that the RCA comes here. So that's the posterior descending artery, and with its septal branches over there. So that is how it is looked at. And the more proximal, so more likely the basal segments. And that again may not be that reliable, but it can be used whenever it is there. And you have these various segmentations. You have the anterior wall, the anteroseptal wall is there, and then the anterior wall, anterolateral. Again, you have the bullseye, which is there at different levels. So this again is something which we are all very familiar. For those who are sort of new to it, so you need to spend a little time to understand this. It is just that you have all the three images telescoped into one bullseye, and then everything is sort of nomenclatured, and you can look at it in a very systematic way with the apex right in the center. You have these two segment two societies which gives you, so they're still in use. You can use the 16 segment or the HS17 segments, but now more and more everybody's starting to use 17 segments a little more often. And the distribution, again, just to summarize, so this is the LAD, which is the left coronary, which supplies a large part of it. So in the earlier era, it was always called as a widowmaker, because every time the left coronary artery got involved, so that means the mortality was quite high. So you can see that a huge part of the left coronary covers a large part of the left ventricle. Then this is an example of the inferior wall here. So the image was not moving. I think I'll move on. So inferior wall MI was there. And then again, in short axis, you can look at pericardial effusion. So you can see a swinging of the heart, very large circumferential pericardial effusion. So this is, again, look for any the measurements, any other findings within the effusion itself. And in the when you look at the mitral valve, so you can look at where the jet is coming in terms of the mitral regurgitation, multiple jet, single jet. You can see that the MR here is coming from the A2P2 area here. So you can localize the regurgitation. And then one can look at the pulmonary artery also, very low yield as far as thrombus on the right side is concerned. You can see that there's a big thrombus lodged in the right pulmonary artery. So you should always be a little, sort of, you don't miss this, especially if it's in the part of it. So anything more distally, the CT takes up, and echo is not very useful in the proximal areas. So the yield of thrombus on the right side is low, but generally it should be done. We are more of is ruling out rather than ruling in over here. And then the aortic, the pulmonary artery itself has got these measurements. So you have use for this pulmonary artery. So again, in the MPA is measured between the annulus and the bifurcation, somewhere in the middle, and more than 25 millimeters, it is going to be dilated. Always a little bit of a problem, because the one part of the wall is always going to be a little hazy because of the window. So if you find a bad window, don't use it. And when you're looking at the pulmonary valve Doppler for pulmonary hypertension, these are the various findings in terms of pulmonary hypertension and acceleration time. So many other findings, just an example of how you can utilize it. And also look at pulmonary hypertension in terms of the flattening of the septum, so that whether it's a volume overload or a pressure overload. And again, you have these calculations of what is called as the eccentricity index. So this again, more of visually sort of you can easily make out. And when it is circular, LV circular, which is more of volume. So when it is flattened even during systole, that means it is more of a pressure overload here. So I think these two views have a lot of things to be aware of in terms of anatomy and measurements, and the pathologies are many. But generally, many studies which have shown that compared to the other views, the Parasternal views are much easier to obtain because of the reliable landmarks, and you can get a lot of good images, and a lot of pathologies interpretable, and a lot of measurements can be there. It has its limitations, so one should be aware of that. Thank you.
Dr. Satish, that was absolutely brilliant and awesome presentation. I just want to highlight 2 points. One is you mentioned about the RV inflow. Many of the people are not using the RV inflow, and they just do the apical 4-chamber. RV inflow is very, very important for detecting the divided right atrium. In fact, in the past, they used to detect it in autopsy, but today, a good echocardiographer can detect the divided right atrium or quadratum dexter in a RV inflow, and that is very good. And especially when you do the contrast, you can see whether there's a fenestration or not. And in one of the slides, you showed the MR in the short axis, and there, the beaded appearance was so classical. So one can tell the etiology of the MR by looking at the mitral valve and the mitral valve prolapse in the tip. That was a brilliant presentation. Thank you very much.
Thank you, madam. Thank you. Dr. UP, you're muted.
I was my mic. Okay, I think the wonderful presentation, sir. Hats off. Self-explanatory and so clear and so exhaustive. We didn't miss anything, whatever was required in the parasternal windows. So that always makes you that, untitled for Guru Purnima. Congrats. Right. All right. I think we'll move on to Dr. Vijayalakshmi. She's been already delivered a talk in the past, and now she would be talking about echo in congenital heart disease, which views, and there are a number of views which we don't actually use in adult cardiology. So over to you, ma'am. Please take us through the special views which we need to do on.
Yeah, thank you very much, Dr. Singh. In fact, wish you all a very happy Guru Purnima. And then Guru Purnima is special for like a relay race, a guru gives it to the students, and the students in turn, they give it to the next generation. So, in fact, almost all the views are already done, and the audience may think why we are repeating. So for any good student, repetition is like revision. So we'll have the repetition, but then, we'll have an idea of how to think about in the future. So the diagnosis of cyanotic congenital heart disease represents the epitome of applied clinical logic, and correct inferences are drawn from the accurate observations, and the diagnoses are made with the gratifying frequency. But today we have echo, which is more brilliant. And that today the technology of echocardiography has grown by leaps and bounds and has become an essential part of diagnosis of congenital heart disease. So much so that it has almost threatened the supremacy of clinical examination, catheterization, and angiogram, which is considered as the gold standard for the diagnosis, especially for the complex congenital heart disease. And hence it is very, very important, because one of the most wondrous features of innate nature is surely the most perfect harmony existing between the structure and the function. That's what John Hunter said. But whenever the structural deformity or the abnormality occurs, the function also changes. And here in the pediatric age, the inverted image of echo is a very, very important, because structural and functional defects are seen like how the surgeon sees on the operation table. And that's how we know the inverted image is most important in pediatric echocardiography. Apart from the regular views that we have already seen, the important ones are for the dextrocardia on the right side, and the parasternal short axis, and above that the ductal view and the crab view in the suprasternal view. So these are very, very important. But one thing people should remember, that segmental approach is very important in congenital heart disease. You must go from the atria to the ventricles for the AV connection and the great artery VA connection. Unless you go systematically, your house will be collapsing. And that's how we know it's very important to go for the sequential echocardiography. Venous segment includes both the systemic as well as the pulmonary veins and the coronary sinus. The great veins are systemic, that is a superior vena cava, left SVC, that is a persistent left superior vena cava, inferior vena cava, and the hepatic veins. And then we have the coronary sinus. And apart from that, 5 pulmonary veins are there, but 1 from each lobe of the lungs. But we see only 4 when we do the echo. We know arterial connection, how and to what great veins are connected, that has to be looked for. Atrial segment includes the RA, LA, and interatrial septum and the atrial appendages and any other anomalies. Now, we should be able to distinguish a morphological right atrium from the morphological left atrium as well as the appendage, and detect any membrane in the either right atrium or the left atrium. All these have to be looked for in the various views. So basically, the subcostal view is the excellent one for many reasons, and most of the diagnosis can be made in the subcostal. The first thing that you do is in the subcostal is the situs, detection of the situs, which is very important in any congenital heart disease. So when you have a 2 circles, one with the red and other one with the blue, the red one with the Doppler, you can detect it is the aorta. The blue one, you can detect with the Doppler 3-phase, that is the IVC. And in the situs inversus, the aorta will be on the right and the IVC will be on the left side. And in the situs ambiguous, and it will be different, and then that requires the either CT or MRI to detect further. So only in this case, you can see that aorta is seen, and there is no hepatic portion of the IVC. And this happens whenever the interruption of IVC is present. And here you can see that the azygous system is draining the IVC blood into the right side, that is the right atrium. So in the subcostal view, we can detect the pericardial effusion because the echogenicity of the liver, it offers a greater view to sweep to evaluate for the further function. So pericardial effusion can be detected very well. And in this, you can see that apart from the pericardial effusion, there is a mass in the AV groove, and that also can be detected in the subcostal view. And this subcostal view is very important because dilated IVC non-collapsible can be detected in this view. And the pericardial effusion, and that is usually due to the pericardial effusion with tamponade, constrictive pericarditis, recessive cardiomyopathy, right heart dysfunction, pulmonary hypertension, ASD, RA inflow obstruction, tumor or the thrombus in the right atrium, and AV fistula and left common iliac artery, and also aortocaval fistula. All these conditions can lead to the dilatation of the inferior vena cava. And if you find the SEC, that is a spontaneous echo contrast in the IVC, it indicates that there is an impaired flow into the, and there is a stasis or membrane or an obstruction in the above. So here you can see that there is SEC is present in the hepatic veins as well as the IVC. And here the subcostal abdominal view images of the suprahepatic portion of the IVC and upstream from the entrance of the hepatic veins, connecting to the morphological right atrium. And already this is also good view to see the eustachian valve, which Dr. Singh has already shown you. So here you can see that the hepatic veins are draining directly into the RA without the IVC. So IVC is interrupted. And then in this case, you can see that the hepatic veins are draining not in the RA, but in the left atrium. So directly into the left atrium. And this is the part of the total anomalous systemic venous connection. So IVC is draining into LA, and SVC also will be draining into LA. And here you can see that the SVC is draining into the dilated left atrium. Left atrium is dilated because left atrium and left ventricle, because both the systemic veins, that is the IVC as well as the SVC, are draining into the left atrium. And that's why you are getting the 3 jets inside that. So here SVC is seen draining into grossly dilated left atrium, and this is the part of the systemic venous anomalous. So this was a 15 days baby. Emergency transthoracic echo was done, and in the subcostal region, this is what I saw. And this is something amazing. And anybody, I mean, it is like a googly ball, and it's very difficult to make out. And then it turned out to be hepatic endothelioma. And then at the same time, the patient had vegetation of all the four valves and the non-compaction of the LV. I treated all the infective endocarditis and then took up for the device closure to treat this patient. And this is the 6-week neonate with chest retraction, feeding difficulty, treated as aspiration pneumonia. And already Dr. Singh has shown you how the infradiaphragmatic TAPVC is seen. So here the infradiaphragmatic TAPVC is draining into the IVC, and this invariably there is an obstruction, and as a result the patient has got the turbulence in that segment. And this is the scimitar vein. Oh, sorry, it's not, video is not playing. And then we move on to the subcostal 4-chamber view, which show the cardiac position. In this, we can see the RA, RV, and the RV, LV, and also the tricuspid attachment and any position. So this is the subcostal 4-chamber view, and where you can see that almost the whole sweep of all the 4 chambers are seen, and especially in the sick neonate. And this could be the one view where we can get the whole picture. This is the subcostal short axis aortic view, and where you see the aorta and then the RV and the main pulmonary artery, RPA and LPA. And this is the subcostal 5-chamber view, where the aorta is also seen. And the subcostal short axis mitral valve view also is possible, where we can see all the segments of the myocardium. In the subcostal, we can get the bicaval view, where the IVC and the SVC draining into the RA can be made out. And this bicaval view is very important in the pediatric age group to make out any TAPVC in the supracardiac TAPVC or the IVC interruption. All that can be made out in this bicaval view. And then the subcostal short axis mid-papillary muscle view is very important, because sometimes in the parachute mitral, only one papillary muscle will be there. So in critically very sick neonates, the subcostal window often remains accessible and permits the significant cardiac assessment in the multiple planes. It is thus the vital, and the echocardiographers appreciate the full potential of this subcostal window, as for many patients it may be the only available transthoracic window in the very sick children, where lots of leads are attached to the chest and hardly we have any space in a very tiny baby. So the subcostal view is very important. In a grown-up child, when we are doing the device closure of the AST, this modified subcostal view is almost akin to the transesophageal view. And here you can see that the posterior superior rim and the posterior inferior rims are all very well seen, and it looks like a T in a child. And this helps us to do the device closure without the transesophageal echo, with just transthoracic echo itself. Now, talking about the situs, IVC drainage has to be seen, and the eustachian valve guarding has to be seen. And then the RA appendage, that is the SNOOP, is known, is very easily made out, and that's how we look at it. And the hepatic veins draining also have to be looked for the situs. Now, morphological right atrium is detected by the SVC and IVC draining into the chamber, but of course exception is when there is a total anomalous systemic venous connection, and the eustachian valve guarding it is the real determinant for the right atrium. And the limbus of the fossa ovalis is seen, and the RA appendage is another one, and opens through the tricuspid valve, and that's how the RA can be detected. Now this is the coronary sinus drainage, where the LSVC is draining into the enlarged coronary sinus, and that should not be mistaken as the ostium primum AST. Here you can see that this is a dilated coronary sinus with the Thebesian valve guarding it, and that should not be mistaken as the ostium primum AST. Now, morphological left atrium, the flap valve of the fossa ovalis is there, and more than 3 millimeter pulmonary vein, more than 3 pulmonary veins are seen draining into the LA. The fourth one may or may not be seen in the fourth chamber, and for that you have to go for the crab view. And the LA appendage opens through the, and then this atria opens into the through the mitral valve into the left ventricle. Of course, the variations can be there when there is the ventricle inversions. So LA appendage is a Snoopy's ear. You can see here that this is how the LA appendage looks, like a ear of the Snoopy. And then we have right-handedness or the left-handedness. So situs solitus with the D loop, where the morphological right ventricle is right-sided right-handed, and then if diagrammatically, if you look at it, the thumb represents the tricuspid valve, palm represents the interventricular septum, and fingers represent the infundibulum or the wrist or the apex. Back of the hand is the free wall of the right ventricle. So that is the D loop. And then we have the situs inversus, where there is the L loop. And in the L loop, we have the morphological right ventricle is left-handed, and both are like a mirror image. So these two fingers are like a mirror image in the dextrocardia or in the situs solitus. So this is how we have to look for the L loop and the D loop. Now coming to the juxtaposition of the atrial appendages, juxtaposition of the atrial appendages refer to the condition in which both the atrial appendages are on one part of the other line. And here, it's very important that the appendages lying to the left of the great vessels are called as the left-sided juxtaposition, and is considered more common than the state in which the appendages lie on the right side of the great arteries, and that is the right-sided juxtaposition by a ratio of about 6:1. That means juxtaposition of the left-sided is more common, 6 times more common than the juxtaposition of the right side. And invariably, this juxtaposition of the appendage is associated with the more complex congenital heart diseases like the TJA and the tricuspid atresia. And here you can see that in the subcostal long axis sweep, you can see that this is the left atrium and the left atrial appendage is here. This is the normal one. And whereas here you can see that this is the right atrium, and that the Snoopy's ear is seen in the right atrial appendage there. And this is to the left. So it is the juxtaposition of the right atrial appendage to the left, which is less common. And here you can see that in the apical fourth chamber inverted sweep, here you can see that the juxtaposition of the right atrial appendage here, and as well as you can see that the right atrial appendage is also seen on this side. And this is how we can look at the juxtaposition. Now coming to the parasternal long axis view, anterior leaflet, these are all very important, and already the parasternal long axis is described, but in congenital heart disease, I'll teach you where it is very important. Here, this is the aortic cusp, and just below the aortic cusp, or just 1 or 2 millimeter below, you see a membrane. So that is the subaortic discrete membrane. And this membrane, over the period, it can become like a tunnel. And this is in the apical 5-chamber view, where it is membrane has become so thick that it has become like a tunnel. And here it is almost obstructing. And this patient had a 168 gradient in the LVOT, requiring the immediate surgery. And that's how the tunnel can be there. And parasternal long axis is very important, especially in the TGA. And this is the histopathology, and this is the echo. You can see that the left ventricle is opening into the pulmonary artery, and the right ventricle is opening into the aorta, though great arteries are going like a parallel to each other, like a railway tracks. In the parasternal long axis, it's very important to see whether there is a mitral to aortic continuity is there or not. Normally, mitral to aortic continuity is there, but in a DORV or TGA, the mitral to aortic continuity discontinuity is there, and instead of the continuity, there is a hypertrophic, hypoechogenic fibrous tissue is there in between. And here you can see that this is the aorta and the RA, pulmonary artery, both are arising from the right ventricle, and that is the double orifice, DORV. And DORV is there are totally 16 types depending on the VST position and commitment to the great arteries and the position of the great arteries, combination and permutation. Parasternal long axis is also very important for the LV dimension and also the aorta and the LA. And here you can see that the patient has got the aortic regurgitation, but there is a myxomatous valve which is causing the prolapse. And the parasternal long axis view is important to detect the aortic dilatation as well as the narrowing of the aorta. So supra-aortic stenosis, subaortic stenosis, valvar stenosis, all the three can be made out in the parasternal long axis view. And the dissection flap and the dilatation of the aorta, aneurysm all of the ascending aorta, all can be made out in the parasternal long axis view. And very rarely, this is one of my patients who survived to the 7th day, the hypoplastic left heart syndrome. And here, in the modified view, we can see that this is the pulmonary artery and the coronaries were arising from the main pulmonary artery. And that's how patient survived. So the aorta is atretic, ascending aorta is hypoplastic, but the main blood supply is from the pulmonary artery and the coronaries are arising from the bifurcating artery. So this is the arching aorta is atretic, where the branching pulmonary artery is having the coronary arteries. The hypertrophic cardiomyopathy can be made out in the parasternal long axis view. Parasternal long axis view is also important to detect any membrane in the left atrium or the supra-aortic membrane. Both can be made out. And here you can see that whether there's a fenestration, blood going through that can be made out with the color Doppler. And here this is the 3D and the 4D echo. You can see that the membrane in the left atrium is very beautifully seen, and that is the coronary sinus, and also the papillary muscles and the attachment all can be made out in the 4D echo as if the surgeon is looking into that. Now coming to the apical 4-chamber view, RA size is smaller than the LA. And the IAS is neutral, but IVS is always part of the left ventricle. And note the tricuspid annulus is more apically placed than the mitral annulus. And inverted image used by the pediatric cardiologist is to help the surgeon to make the surgery. So here in the inverted image, you can see that the intraatrial septum has got a large AST. This is the apical 5-chamber view, where you can see that the subaortic membrane is there with the turbulence in the colored Doppler. And this is the patient with apical 4-chamber. You can see that the glistening endocardium is there. And this glistening endocardium indicates that there is an ischemia, subendocardial ischemia. And this patient was treated as a rheumatic heart disease with a mitral regurgitation with the PA pressure. But when I reviewed the echo, I saw in the short axis that the left coronary artery was not arising, and instead it was arising from the pulmonary artery. So this is the Alcapa in a patient causing the subendocardial ischemia and causing the MR, significant MR. Now, apical 4-chamber view is also is important for the Epstein's anomaly. And here you can see that the atrialized right ventricle is making a right atria and the atrialized right ventricle, and the right ventricle, actual right ventricle is very, very small. And this is how it is very important, apical 4-chamber view as well as the apical basic views. And here you can see that the ATL, that is the whip-like movement of the anterior tricuspid leaflet, is very beautifully seen in the parasternal long axis view. So this is how the multiple views have to be seen. And this is the patient where with the only one ventricle has seen the single ventricle, and this single ventricle could be the LV type or the RV type. And here this is the trabeculated, and hence it is called single ventricle RV type. And here you have to look whether it is associated with other problems. So in this patient, you can see that there is a membrane in the left atrium, and this patient had membrane both in the left atrium as well as the right atrium. In fact, the right atrium and the left atrium are divided into 4. It is not the core triatrium, it is the core quadriatrium. And this is how the multiple views have to be seen for the problems. So modified parasternal long axis view can be made into a 3-chambered view, where you can see the aorta, left ventricle and the left atrium. And here you can see that the submitral aneurysm is beautifully seen. And that's how we know modifying the views is very important to make the perfect diagnosis. So here you can see that there is a blood flow through the PFO, right to left shunt, and there is a severe torrential tricuspid regurgitation is there, and the giant right atrium is there. And this happens in the triology of fallow with the pulmonary stenosis. And that's how we have to take the gradient also. The apical 4-chamber view is very important to make the diagnosis of corrected transposition of great vessels. And here you can see that the morphological right ventricle is to the left side and the morphological left ventricle is to the right side. And you can see that the attachment of the tricuspid valve is at a lower level, and this patient had the associated VST with PS. So complete AV canal defect, whether the balanced ventricles are there or the single ventricle repair has to be done, all that can be made out with the apical 4-chamber, and we can calculate the rest of it. And this is the post-op echo apical 4-chamber view. And you can see a very interesting echo here. This portion of the septum is not moving, it is adynamic. That is because that is the Gore-Tex patch put to close the VST. And you see 2 jets are there on the either side of the septum. One on the right side is during the systole, and the one on the left side is during the diastole. That means it is the residual VST on the right side and aortic regurgitation on the left side. And this is how the post-op echo, when you are doing, you must time the jets and find out where they are. So parasternal short axis, Dr. Satish showed very beautifully, where you have got the 2 papillary muscles on either side. And this is very important because in children, you can have a parachute mitral where the single papillary muscle is seen. And here you can see that only single papillary muscle is there, and that is the mitral valve parachute. And this is attached at the apex, and that is causing the thing. And also there is a supramitral ring here. So single papillary muscle parachute mitral valve should not be missed. And along with that, you can see that there is a supramitral membrane or the supramitral ring. And apart from that, there is a supra-aortic stenosis, narrowing of the supra-aortic, the ascending aorta. And this was a part of the Schoen's complex. And this is how we know you should not be happy in detecting one point in congenital heart disease. You have to detect the associated lesions. So completely, the complete diagnosis has to be made. And this is the double inlet left ventricle. Both the tricuspid valve as well as the mitral valve are opening into the single ventricle, that is the LV type, this is smooth walled, and in the short axis both are seen, and the tricuspid and the mitral valves are nicely seen. So tricuspid atresia, in the inverted image you can see that there is the thick atretic tricuspid valve, and there is a small VST and the pulmonary stenosis. This is very important for the diagnosis. And here in the parasternal long axis, when there is a overriding mitral to aortic continuity is there, we have to look in the apical 5-chamber view. And in the apical 5-chamber view, we have to see that the overriding of aorta is very beautifully seen. Now coming to the short axis in the base of the heart is very important. This is how you look at the short axis. And here you can see that the bicuspid aortic valve, only 2 cusps are there and 2 raphe. And this is how the bicuspid aortic valve or unicuspid aortic valve can be made out. In a parasternal long axis, you like a cup and the saucer. This is how the aorta looks, and then the pulmonary artery looks like a saucer. And this is the normal one. But whenever there is a pulmonary artery atresia, pulmonary atresia is there, pulmonary valve will not be seen, pulmonary main artery is not seen, but the confluent RPA and LP are seen. And this is how you can make out that the pulmonary atresia is there. And apart from that, in this patient, there is a vertical duct supplying to the pulmonary artery. Because the blood is not going to the pulmonary valve, there is a vertical duct supplying to that. So here it is very important the pulmonary valves are absent. This is called the dysplastic pulmonary valve, where they look like a rudimentary buds, and then there is a free pulmonary stenosis and the pulmonary regurgitation. The annular narrowing makes it as the stenosis, and absent pulmonary valve makes it the free pulmonary regurgitation. So these things can be made out in the short axis. And apart from that, unicuspid aortic valve also can be made out. Unicuspid, bicuspid, quadricuspid, and tricuspid all can be made out very well in the short axis. And this is a patient, the newborn baby, just 14 hours old, in a hydros fetalis, literally dying, and there was a pinpoint aortic stenosis. And after the balloon dilatation with the PTCA balloon, the child came out of the ventilator, and this is how it looks. The gradient came down, and ejection fraction improved from 30 to 60% after the emergency balloon dilatation in a 14 hours old baby. So the short axis is so important to make the diagnosis of the pinpoint aortic stenosis. And that was the bicuspid aortic valve. And here in the short axis, you can see that the dissection flap is nicely seen, and then there is a aortic regurgitation. And once you see the dissection flap, you have to go to the logical end. In the short axis, as Dr. Singh showed the coronary artery, and here you can see that the right coronary artery is very huge and it is dilated. And where is it draining? And you can see that it is draining into the pulmonary artery. So in the short axis, you can see the coronary arteries as well as where the coronary AV fistula is draining. So this is how we can make the diagnosis in the short axis. And the short axis is very important, especially in tetralogy of Fallot, where the coronary anomalies can be there, and they can the abnormal coronary artery going across the RVOT can be seen. And apart from that, instead of cup and saucer, if there are aorta and the pulmonary artery which are transposed, and they are looking like the owl's eye. And this owl's eye, is classical because both are seen at the same level, and both are at that. But what happens is when they are transposed, they are like a owl's eye. But when there are malposed, they are anterior and posterior. So aorta is anterior and the pulmonary artery is posterior, or vice versa. So they'll be going like a parallel. Great arteries will be going like a parallel to each other. The short anterior to the right and the pulmonary artery is posterior, dividing into two branches, and the tiny PDA is seen in this patient. That is the tiny PDA. So this is how we should be able to distinguish. And DTGA with the parallel great arteries, and the PA from the LV, aorta from the RV, and the tiny muscular VST is seen. And this is not enough. So we have to decide whether the duct has to be kept open, and then that duct has to be either stented or not. And here you can see that this is the single great artery is arising from both the ventricles. There is a large VST, and what is important is from the ascending truncus, the single great artery, the pulmonary artery is also coming. And this is how it is very important to make the diagnosis of truncus arteriosus. Now coming to the ductal view, the probe is positioned in the complete sagittal fashion along with the left border of the sternum above the level of the parasternal short axis. The marker has to be pointed toward the head and then gradually turn. In this ductal view, you can see that this is the aorta, this is the ampulla, and that is the pulmonary artery, that is the duct. So to put the device closure, to measure the size of the device, we have to, this ductal view is very, very important for most of the pediatricians, and without this, the device closure of the duct is not possible. So here, the piccolo in the newborn baby, with the echo itself, the duct closure is done with the piccolo, that is the ASD to AS, ADO to AS. So this is the how the echo helps us to put the device closure in a very sick neonate with a large PDA without shifting to the cath lab. So the ductal view for stenting the duct is extremely important. And then our management strategy depends on the measurement of the length of the duct. And then we have to take the stent depending on the length of the duct. And this is how you can see that the patient, after ducting the stent, this is how the flow is through the duct, which is stented. And this is, the ductal view is extremely important to make the diagnosis. In this 36 years old patient, the collapsing pulse is there, and you can see that in the modified high ductal view, the blood is going from the pulmonary artery into the aorta, that is the right to left shunt in the PDA with PH. So in the suprasternal view, this is the vertical duct which is supplying to the pulmonary artery, and the vertical duct will be missed in the regular view, and that's how the ductal view is very important. This is the 10 months old patient with almost like a bilateral Harrison sulcus, and somebody had made it as just congenital heart disease with AST PH. But when I did the short axis, I could detect that there was a AP window, and this AP window was closed with the device, and this is how it looks after the device closure. The AP windows have to be detected in time and closed with the device, or the surgical correction has to be done in time. The suprasternal view is very important, and here the coarctation of aorta and the gradient all can be made out. And apart from that, the suprasternal long axis view shows the descending aorta, and you can, with the color Doppler, you can make out that there is a narrowing of the narrow segment in the coarctation. Associated PDA also can be made out. And in this suprasternal view, you can see the flap of the dissection of the arch, as well as when you come down, the thoracic as well as the abdominal aorta can be made out. So single coronary ostia is seen in this patient. The left is not seen, and the aorta is hugely dilated. And this is the important patient. This is from L. Srinivas. And this is the associated TJ with the pulmonary stenosis with the bidirectional glen. You can see that this is the glen, and that is how the SVC is connected to the pulmonary artery and causing, allowing the blood of the SVC go into both the pulmonary artery branches, and that is the bidirectional glen. And this is the TGA with the PA-PVC. Now, most important crab view for detecting the pulmonary veins, and here the crab view is a coronal plane image obtained with the transducer in the suprasternal notch. It is called as a crab view because it looks like a crab with the 4 legs. And here we have to turn our knob so that it is in the 3 o'clock position. The indicator is in the 3 o'clock position. And here what happens is, this is how the crab view is seen. This is the upper pulmonary vein, and this is the lower pulmonary vein, left lower pulmonary vein, and this is the right upper pulmonary and the right lower pulmonary vein, and all of them can be made out. And this is how in the supracardiac TF-PVC, you can see a figure of 8 also can be seen. And this is how the crab view and the suprasternal views are very, very important to make the diagnosis. This is the intracoronary TF-PVC, where the coronary sinus is dilated and the whole blood is going into through the coronary sinus to the right atrium. And then the intracardiac TF-PVC, already Dr. Singh has shown, this is how whether it is obstructed or not obstructed can be made out with the pulmonary vein that is going down into the condition. The venous confluence is behind the left atrium, and when the anomalous venous connection is there to the coronary sinus, that should be made out. So in the dextro position, we have to keep our probe into the left side, and there you can see that the mirror image dextrocardia, you keep it on the left side. The whole apex and the LV and RV are on the left side, and the apex is formed by the LV. Apical four-chamber view can be made out on the right side, and then we can see that the mirror image dextrocardia, where the apex is formed by the left ventricle, and then we have to do the apical four-chamber view from the right side. And the parasternal long axis also can be done beautifully from the right side, and the right side short axis also can be got from the right side, with the almost getting the same image as the aorta and the pulmonary artery. And the take-home message is the most common view in the pediatric cardiology is the inverted image. And the inverted image is almost like how the surgeon sees the structure. So subcostal view gives the very important information of the situs, IVC, SVC, anomalies, infradiaphragmatic TAPVC, IIS, PFO, and the AST. And the parasternal short axis view helps in the aorta and the PA, PDA, rupture of sinus of Valsalva, locate the VSTs, coronaries, and the coronary AV fistula. Ductal view is for the PDA and also for the stenting as well as the device closure of the PDA. The crab view is for the pulmonary veins to be detected, and the dextrocardia positions are already as described. So friends, we can say with some assurance that the children may be victims of fate. Let them not be victims of our neglect. Know the views that is important for the pediatric patient. Make the perfect diagnosis, if not very perfect, near perfect, and give it to the surgeon so that early intervention can be done by either the interventional cardiologist or the cardiac surgeon, so that the patient can be saved and they should not be neglected. So use the special views in pediatric case, put in extra effort and passion to make your precise diagnosis, to assist the interventionalist and the cardiac surgeon to save the precious life. Thank you very much for your kind and the patient hearing. Thank you very much.
Thank you, ma'am, for such a wonderful, presentation, and so many cases to actually go through it. And I think this is very, very important to see all those cases, because this is a kind of a pattern recognition. You actually see one case, and then next time when you see a case which is rare, you can always refer to the
Yes.
pattern, what you've seen in the past. Otherwise, once you see a view and an image, at least as of now, there is no help from Google Lens or anybody else to tell you what it is all about. A fabulous presentation as usual, and such a large collection of cases which speaks volume about your number and quality of work what you're doing, ma'am. And hats off to you. Sure.
Thank you very much, sir. I'm sure the audience, once they see these rare cases, next time when they see, immediately they recognize. And that's the importance of a teacher teaching the disciples. And Guru Purnima, best wishes for all of them. And I thank you for organizing such a wonderful webinar on the basics. Always we go to the top, talk about the 3D, 4D, and that is the tip of the thing. But the base is the basics. And that's how I congratulate you for wonderful webinar. Thank you.
Thank you, ma'am. Thank you very much for that. And think what we need to, we are really grateful. And now this comes to an end. All good things come to an end. So, dear delegates, colleagues, those who joined us today, we conclude this comprehensive day-long webinar on echocardiography. And I want to extend our deepest gratitude to each one of you who participated here, with over 2,000 delegates and all across the world, about 81 countries. Your engagement, enthusiasm is very obvious. The special thanks to my distinguished colleagues, the speakers, the gurus, whose insight and expertise have greatly enriched the understanding of echocardiography. And your contribution, of course, is invaluable. My special thanks to our sponsors, GE. Currently, I am using GE machine in 995, and the workflow with GE machine is so wonderful with the AI inbuilt into it. And not only that, the AI is there, the learning is there in your machine system also, so that it learns the way you perform an echo and adjusts accordingly. So
And the
my
4D echo in G is excellent.
Yes, ma'am, I fully agree with you. The kind of the 3D analysis, once you acquire the volume, we were able to see when Mr. Ashish, who's wonderful operator, who is a application specialist, we were wondering what the small outpouching was. It was a less than a centimeter outpouching from the right atrium, which was a right atrial small diverticulum. So, I mean, that's the power of 4D. And I now believe that if you do a good 4D, you would be able to pick up even sinus venosus ASD. You don't probably have to go to subcostal views for that. And Samsung is another sponsor.
Sorry for interrupting. In fact, the reconstruction, 3D reconstruction is not needed when you're doing the 4D echo. And
Yes,
that to that
right.
extent, it is so wonderful, the cost effective.
Absolutely, ma'am. And then Samsung is another sponsor there. I'm using their machine. In fact, my unit has about 8 ultrasound equipments, color Dopplers, and 3 or 4 of them are from Samsung. I had been an ex-user of Philips, so my images you saw from all 3 leaders of medical imaging equipments. My thanks goes to Mr. Tarun and his team, and Mr. Pankaj Aswal, Mr. Rishi, who made this webinar look seamless because of their efforts and constant inputs. We hope that you found these sessions informative and inspiring. This webinar would be available on a YouTube channel, and I mean, the name is also quite catchy, Eco Sing. So you can always go to that YouTube channel, and it would be available for you to see it, review it again and again in case you need. But we're still looking for, your feedbacks, your critical analysis, and also suggestions for doing better in the future. So thanks again for your time, your dedication to advancing this field of echocardiography and strengthening our foundations of echocardiography here. So, with regards, I am Dr. UP Singh from Chandigarh, India. Bye for till we have another webinar, and I would share that information with you guys. Thank
And
you very
hearty
much.
congratulations to you, Dr. Singh, and your team.
Thank you,
Have a
ma'am.
wonderful good night and good evening and good morning to many.